Okay, when you say cataract, what is cataract? We come to pathology. After discussing your anatomy and physiology, we come to pathology. Then first, very important is cataract. I know the definition is in front of you, but what is very important to understand, I think basic should be clear that cataract kya hai? If this is your eyeball and this is the lens, if this lens is clear, naturally the light rays are going to fall nicely on the retina, and if there is a nice focusing, we can see clearly. Correct? But suppose there are any opacities in the lens, then definitely this is going to stop some light rays. When it stops some light rays, this causes diminution of vision. So, opacity in the lens, which is affecting the vision, the optical homogeneity is being disturbed. That is called cataract. So, cataract, if you have to define it, this is the correct definition. Any opacity which hinders with the optical homogeneity of the lens, right? Then we talk about the classification. What are the types of cataract you should know? So, when we talk about the types, we divide the cataract as congenital and acquired, right? Now, this congenital and acquired can be further divided. Congenital can be divided as, if it is happening less than 1 year, we call it infantile, or which is infantile means mainly embryonic and fetal nucleus. Why we say so? Because it's less than 1 year. Fetal nucleus is up to 8 months, isn't it? So, you have to know this way. Whereas developmental is more than 1 year. That is called development. Coming to acquired. We can classify acquired anatomically. We can classify it according to maturity, or we can classify it etiologically. Right? Okay. So, we now then next talk about congenital cataract. So, when you say congenital cataract, what did we learn? It can be infantile or it can be developmental. Okay, before going to the types of congenital, let's talk about etiologies of congenital. Now, very simple, I am giving you one tip. All the factors that you ever remember for any congenital anomaly will apply here. Whether it is tortuous infections, radiation exposure, teratogenic drugs, some metabolic causes, some genetic cause, and so on. Okay, so let's have a look at the etiologies. First etiology of congenital cataract is tortuous infection. It should be torch S as also. I would like to add in S here. So, it's a torch S infection. Everybody knows what is torch S? We are talking about toxoplasmosis, right? Rubella, cytomegalo, herpes, and syphilis. So, this I've just said, I don't think we need to write it. You all know this, right? I'm repeating: toxoplasmosis, rubella, cytomegalo, herpes, and syphilis. These tortuous infections, if it is happening in first trimester, can lead to congenital cataract. What can be the second cause? Genetic cause. Okay, so what are the points to remember here? There may be positive family history, number 1, and the inheritance is autosomal dominant, right? And another, this is important exam question. What are the genes responsible? Okay, what are the genes responsible in congenital cataract? They can ask you. What will you answer? Cry genes, number 1. Cry stands for crystallines, right? What is the next? Connexins. CX is connexins. These are connexins, crystallines. Then write down connexins. And MIP, that is major intrinsic protein. Major intrinsic protein, right? So, this was exam question. The question was on cry genes. Which cry? Cry G genes, gamma, okay? So, it is cry G, right? So, mainly the crystallines. We are talking about that protein. Okay, then this is the gene responsible, and we should know this very well. We next talk about what is the next cause. Can be radiation exposure in first trimester. We all know that. And another one is teratogenic drugs like thalidomide. Next talk about is hepatic disorders, and here we have to learn Wilson's disease. Second can be chromosomal abnormalities, right? In chromosomal abnormalities, you can learn Down syndrome. So, this is an exam question. What type of congenital cataract happens in Down syndrome? And we answer blue dot cataract if you want to know this. So, what type of cataract? It is blue dot cataract. We'll talk about it and have a look at the different types of congenital cataract. Okay, we next talk about is metabolic cause. So, when you say metabolic cause, we have to remember our galactosemia, Loeys syndrome. Okay, galactosemia number 1, So first is your galactosemia. We'll be learning what do you get in galactosemia? Oil droplet cataract. Then again an important exam question. What we get here is oil droplet cataract. I hope we are making the cues. And second, after galactosemia, next would be, what is the next cause I said? Loeys syndrome. Loeys is oculocerebrorenal syndrome. We'll talk about it again in the acquired section when you talk about acquired cataract. So, Loeys syndrome, we can get metabolic cataract, right? And what is the third is Fabry's disease. We'll talk in detail about Loeys further in this chapter. Then Fabry's disease. So, these are important metabolic causes that you have to keep in mind. So, these were the causes of congenital cataract. We next talk about the types of congenital cataract. What can be the different types? All the names you see in ophthalmology, majority of the times you're going to realize that all the names are based on morphological appearance. Jaisa dikhta hai, whatever it looks like, we are describing it. Okay. So, first is of course, we have divided in, this slide is showing you that we have divided into infantile and developmental. So, the first we talk about is blue dot cataract. So, when you are going to have a look at the blue dot, you see let's make it for ourselves before we start looking at the slides. We can draw this for ourselves. So, when I am looking at the lens, what I see are the bluish dots on the lens. This is called blue dot cataract, right? This next type of cataract, purulenta. Purulenta means powdery appearance. That is called purulenta. Okay, it has powdery appearance. What is the next? Lamellar or zonular. Very, very important. Lamellar and zonular is also exam question. This is also exam question. When you talk about lamellar or zonular, what you will say? A single lamella is cataractus. Suppose this is the lens. One lamella is cataractus. But adjacent areas are clear. So, it is one lamella which is cataractus. Suppose this is showing in a different color. But adjacent areas are clear. So, these are the simple diagrams for ourselves so that you can make it along with me. So, that is your zonular or lamellar. We'll also learn that in addition to this cataractus lamellae, we see some small spoke-like opacities on it, and this is what we call riders. Okay, these small additional spoke-like opacities are called riders. They are just additional opacities on the cataractus lamellae, nothing else. Okay, let's first have a look other type of congenital cataract. Next is anterior polar. When you say anterior polar, we know where is the anterior pole of the lens. We'll draw it for ourselves. If this is the eye and this is, we are saying this part of the area, this area is all cataractus. Next is posterior polar, which will just be the opposite. And next is total congenital cataract. Okay, so if you want to draw along the oversimplified diagrams that I draw, we can draw it together here. This becomes your posterior polar very quickly, and then comes your total congenital cataract, which means the whole lens is opaque. Right? Next type of congenital cataract that we have to keep in mind is coronary, which are nothing but peripheral cortical opacities. And what is sutural cataract? We know what are sutures. So, any opacity along the sutures. I talked about straight Y and inverted Y. So, these are sutural cataracts. Let's have a look. So, blue dot cataract, as you can see here, is the most common congenital cataract. If they ask you overall which is the most common congenital cataract, it is blue dot. I think you can see these bluish opacities here, right? Next slide is powdery appearance. This is your cataracta purulenta, right? So, if you look at this cataracta purulenta, the opacities have, all these are powdery appearance, right? No questions here, but you should know this. We come to the next one. This is what, can you see the lamellae? I think this should be absolutely clear. This is the corneal section here, isn't it? This is the corneal section. So, when the light is shown, this is the cornea, slit of the cornea that you see. Then, section you see, then coming to this one is the lens. Now, when you talk about lamellar or zonular cataract, we have to keep in mind, if you can see here, the peripheral part of the lens looks, this is the capsule and the peripheral part, and inside it is the nuclear part which is involved, right? So, what you have to keep in mind here is that it is mainly the fetal nucleus, please note it down, which is involved in lamellar cataract. You can also note down this that in blue dot, when you talk about blue dot cataract or cataracta purulenta, right, both nucleus and cortex are involved. Whereas here also nucleus, that is what you are seeing here, and you can even see the radial opacities. These are all riders which are additionally seen here in the lamellar cataract. Again, this is the lamellar cataract with the riders in this view, right? So these are all riders which are shown here. These are nothing but this is exam question, so keep in mind. Another exam question I'm reminded of, please note it down, that which vitamin deficiency leads to lamella. So if they have asked you the etiology of the lamella, you will answer vitamin D deficiency. Next question, any other cause? Yes, other causes will be rubella infection. We will take rubella in detail. So rubella infection, these can be the causes of lamella. Overall, most common cataract, I told you congenital is blue dot. But if they ask you most common type of congenital causing marked diminution of vision, so marked diminution of vision, then it is lamellar. So most common causing visual acuity is diminishing, marked diminution of vision. Then most common, please note this down, this exam question, congenital cataract causing marked diminution of vision, you should answer lamellar cataract or zonular cataract. If you think about, it also becomes one of the most, because infantile is within 1 year of age. This is involving the fetal nucleus. You remember we just read embryonic and fetal nucleus are, or involvement is infantile. So this becomes the most common infantile congenital cataract. Okay? So most common, you can note down another point here. This is the most common infantile congenital cataract. Done? What is the next? Next what we see is, this is posterior polar cataract. So posterior polar cataract, one important point, please all of you keep in mind that posterior polar is mainly associated with what? Generally Mittendorf dots. We will learn in the vitreous chapter, Mittendorf dots are associated with posterior polar cataract, and these are nothing but a remnant of hyaloid tissue. What is hyaloid tissue? Primary vitreous. Giving you a quick brief here that the vitreous during embryonic development is mesodermal tissue. It will regress and it is replaced by hyaluronic acid and type 2 collagen, which is called adult vitreous or secondary vitreous. Okay? Initially, it is just a mesodermal hyaloid tissue, right? So, when it is regressing, some part can remain, and that is leading to, that is what is called remnants of the different remnants of vitreous or hyaloid tissue that remain. We are going to learn more of it in the vitreous chapter. This is Mittendorf dot. So, we will just write a remnant of hyaloid tissue. Okay? Okay. Another important thing that you have to keep in mind is onion ring appearance. Okay? So, this posterior polar cataract is showing you the onion ring. You can see it round. This type of appearance. This is onion ring appearance. What is next? So, this one is your peripheral opacities, cortical opacities, which are called coronary cataract. We can also note, what is this? I can see a straight Y. This is a sutural cataract. Okay. So, this is what is sutural cataract. And what is this? This is total congenital cataract that you are seeing, where the whole lens is opaque. Another important point is when you talk about anterior polar cataract, what you have to know here, that anterior polar cataract, of course, involves anterior pole. This is clear to you all. Important point, it is associated with persistent pupillary membrane. Just remember this point. It is associated with persistent pupillary membrane. When we were talking about the etiology, what you have to keep in mind, generally they are all these cases of congenital cataract are bilateral. What are the unilateral cases? So, instead of this, please note down the next cause here is birth trauma. We are talking about birth trauma here. And apart from birth trauma, one important thing that you have to keep in mind is that this is a unilateral cause of unilateral congenital cataract, isn't it? So, we will learn here when we go back to etiologies and think congenital cataract is generally bilateral except two places. One is your birth trauma where it is a unilateral case, and second unilateral case is some cases of ROP. We will remember some cases of retinopathy of prematurity. We will learn this more in detail in the retina chapter. This can also lead to your unilateral cases of congenital cataract, right? So, that these were the etiologies and different types of congenital cataract. So, I hope you are not going to forget The important questions, most common type overall is blue dot, but most common causing marked diminution of vision, it is lamellar. Which vitamin deficiency? Vitamin D. Right? It is one of the most common cause of infantile cataract. What else we learned very quickly? That mainly posterior polar onion ring appearance, please exam question hai. When you talk about the posterior polar, also keep this in mind that because this posterior polar is adhered to the posterior capsule, this is a very big risk that when you are operating on this patient, you can lead to posterior capsular tears. Okay, we'll keep this in mind. Right. So, onion ring appearance, again very important point they have asked you. Okay, so I hope if we have missed to make the cues, you will make the cues on all these slides. Make the cues. Okay. Then we talk about, after all these types of congenital and what are the questions that has been asked, our next important thing is congenital rubella syndrome. So, this is another topic on which the question is asked. When you say congenital rubella syndrome, first question is, what is the triad? So, do we all know the triad? Yes. We can learn the triad as CHD. The mnemonic is CHD, where C stands for cataract, H is heart defects, and D is deafness. Cataracts, heart defects, deafness. Right? Okay. Once you know this, next question, most common type of cataract. Please answer most common type of cataract. We will answer is nuclear pearly. Yes, we learned that lamellar rubella can be a cause of lamellar cataract, but most common when they ask you, you have to answer nuclear pearly cataract. Okay? Yeah. Are there other ocular features? Yes. So, whenever we are learning the ocular features, you will learn in my simple way. We make a diagram and start thinking from outside to in. So, let's do it together. You will know what I mean. So, suppose this is we are talking about a simple diagram of eye. Here, so very quickly, iris, this is your pars pliccata, pars plana, right? And this is your ciliary body, and this is your ciliary body, and this is your choroid, sorry. And this dotted line is your retina, right? This is the lens, and this is the suspensory ligament. Lens should have been little better, it's more flatter. So, okay, we make the lens again. This is the lens, and this is the suspensory ligament. Right, all of you? Chalo, once you know this, what are the ocular features of rubella? We start thinking from outside to in eyesight. So, what happens in the eyeball? Is there any finding in the eyeball or not? Yes. What you get is, note down, we will just label it and we'll learn it. That is simple. Microphthalmos. Do you all know what is microphthalmos? Small eye. How much small? When do you call it microphthalmos? Is very important exam question. You will answer when the axial length is less than 21 millimeters. Or at 1 year of age, the axial length of less than 19 millimeters. So, these are the two criteria. Very important cue, I hope you have noted down, is about what is microphthalmos. What is the second? The second feature we will learn. So, that was the eyeball finding. Cornea, do we get anything? Yes, rubella keratitis. We can get rubella keratitis. Right? Anything in the anterior chamber or angle? Yes, angle anomaly. Here, angle anomaly can lead to glaucoma. Right? Anything else? Yes, we just learned as nuclear pearly cataract. Right? So, cataract or nuclear pearly cataract. See how easy it is to learn the features if you just draw on the diagram and start thinking one by one what can be the findings. What is the last finding here you have to keep in mind is in the retina, you can get salt and pepper fundus. Okay. So, when you say salt and pepper fundus, what does it mean? Fundus kya hai? Fundus is what you are seeing through the ophthalmoscope, the retina, choroid, this is all fundus. Right. So, salt and pepper means when you look at the patient, when you look at the retina, some black pigments are all scattered around as if some pepper is scattered. This is called salt and pepper fundus. So, why will there be any scattering of the pigments? Please understand, rubella infection is causing chronic or diffuse chorioretinitis. I would say diffuse chorioretinitis. And because it is causing a diffuse chorioretinitis, due to this inflammation, there is this dispersion of the pigments which looks like salt and pepper. That is what we are saying is salt and pepper fundus. Right, all of you? These are the findings. Exam question. Okay, most common cataract. Okay, please keep in mind, most common cataract when they ask you, we are saying is nuclear pearly. Okay, But if they ask you most common ocular feature, please don't answer cataract. It is salt and pepper fundus. Most common ocular feature we will answer is salt and pepper fundus. Second most common you can answer cataract. Right? So that was about congenital. Let's also learn what can be the causes of salt and pepper fundus. Is it only rubella or we have other causes? Yes, we can have other causes. Okay, so let's have a look. This is what is salt and pepper fundus. And this is the case of a rubella where you can see this cataract out here, right? So this is the case of rubella infection. And we can also see the pigmentary disturbance as salt and pepper. Now let's see an even better picture of salt and pepper fundus here. So look at this one. This is what we are talking about. All this pigmentary disturbance, diffuse choreo. So whenever I ask you what is salt and pepper fundus, it's a diffuse chorioretinitis. That should be your answer. Okay. So this is what is diffuse chorioretinitis, which looks like salt and pepper, as if all the pepper has been scattered over on the fundus, right? So this is salt and pepper fundus. Okay. So what can be the different causes of salt and pepper fundus? First you will learn, this is important, is rubella. Second you will learn is syphilis. You can't forget these two, very, very important. Third, there is a variant of retinitis pigmentosa, which is called retinitis pigmentosa sign pigmento. Again, I am leaving it to the retina chapter. We will discuss there. It's a variant of retinitis pigmentosa sign pigmento. Then next you can learn this myotonic dystrophy. Okay, myotonic dystrophy. Okay, myotonic dystrophy, again I am going to discuss this in your acquired section also. What type of it, because it's also learnt as a pre-senile cataract. So what type of cataract it causes is a very, very important exam question. We all know this. I cannot skip this. I have to discuss this even if I am discussing twice. It's very important. We'll answer Christmas tree cataract, isn't it? Christmas tree cataract. Okay, what else that you have to know? Leber's amaurosis. Leber's is a name. What is amaurosis, all of you? You will answer. Amaurosis is, any of you answer me this. Ma'am, amaurosis is a transient loss of vision. No, that is amaurosis fugax. So we will correct ourselves. In ophthalmology, there are three terms. Very important. Let's talk about it. This is also very important, okay? So first is, what is amaurosis? If I ask you what is amaurosis, you will say it is total loss of vision. Isn't it? It is total loss of vision. Right. Then we talk about next is amaurosis fugax. This is your transient loss. The vision that is gone will come back. That is your transient loss of vision in a curtain-like manner. This is important. What is this? Curtain-like manner. So when the vision goes, it goes like this, as if the curtain is falling down. Superior field is gone, central is gone, inferior is gone. And when it is coming back, it comes back first, inferior comes first, then the central, then the superior. So as if the curtain is going down, the curtain is rising up. This is what is curtain-like transient loss of vision. Okay? Right. So what is the third term that you have to know is amblyopia. Of course, we'll talk about in the optics chapter, but you should know what is amaurosis, what is amaurosis fugax, and what is amblyopia? Partial loss of vision. What was amaurosis? Total loss of vision. Amblyopia, partial loss of vision. Okay, so I think a lot of information you have learnt with me. Yes, so we have already seen salt and pepper fundus, so we shouldn't be worrying here. So how will a child present to you? A child of congenital cataract is presenting to you. Of course, he's a small child, he cannot complain of anything. So please understand the presenting feature will be leukocoria. Right? Leuco is white and chorea means pupil. So leukocoria is nothing but white eye reflex. You just saw that in your rubella slide, right? So white eye reflex is what is seen. This is what is leuco. Something white is shining at the pupil. That is white eye reflex or leukocoria. I'm going to talk about in detail about leukocoria and the causes in retinoblastoma, which is another cause of leukocoria. But here one more point. Congenital cataract would be the most common cause of leukocoria. Most common cause of leukocoria is congenital cataract. Okay. We come to, okay, before talking about the treatment, we'll talk about investigations first. So when you talk about the investigations, first let's give the heading investigations. Any management, we first will investigate here. Let's learn like this, that we are going to go for ocular investigation and systemic. Ocular, of course, you're going to go for a detailed eye examination in and out, anterior segment, posterior segment, as much as possible posterior segment. So, detailed eye examination. If I can't see posterior segment due to cataract, I should go for B scan. And of course, you will do an A scan to see the axial length and to calculate the IOL power if I'm planning to put an intraocular lens in this child after doing the cataract surgery. Isn't it? Okay. So, once we know these are the main investigations ocular. Coming to the systemic part, of course, if I know it's a hereditary case, right? Or it is a unilateral. Unilateral, I told you 2 causes. Birth trauma, number 1. Second, I said few cases of ROP. So, we know the cause, we don't need to investigate. Okay. But apart from, so systemic investigation is not done if in hereditary cases, keep in mind, not done in hereditary cases, no need to do in hereditary cases, that is genetic, as well as it is not done and in unilateral cases. Okay, we will remember this. What are the things you have to do otherwise? Of course, serum analysis and urine analysis. Divide like this, we have to go for a serum analysis and urine analysis. When you say serum, you know, you will just learn the causes with me, so think along. Serum analysis, what are the things I will do? Let's start from there, right? So, torches, then of course the glucose levels, the galactokinase levels, and what else? We have to go for calcium, phosphorus and so on. I don't think this will be too much asked. What is asked is more on urine analysis. Let's talk about urine analysis. So, in urine analysis, what are the things we have to know is, all of you, if you will be checking for reducing substance. Let's learn like this. If you see reducing substance, we know we are talking about galactosemia, right? So, you reducing substance, that means we are trying to check for galactosemia. Another thing in urine analysis is amino acids. Check for amino acids. If you see amino acids in the urine, the diagnosis goes more towards Lewis syndrome, right? Okay. What is the third one? Third one is sediments. Any sediments, then the diagnosis is going more towards Fabry's disease, right? So, we will learn like this. Then what next? Of course, copper, it is Wilson's disease, and if it's blood, it is Alport syndrome, okay? So, copper we will learn as Wilson's disease, right? And let's note down, blood is your Alport syndrome. We'll answer Alport syndrome. We all know Alport syndrome. It's a hemorrhagic familial nephritis, right? We'll be learning it in anterior lenticonus. As of now, let's first finish this congenital cataract, right? So, urine analysis is important and asked in the exam. Okay, we next talk about is how are you going to treat the congenital cataract, right? So, of course, the treatment of cataract is surgery. We all know. I'm talking more in details further. So, when you talk about the surgery, what type of, those 2 things that they can ask you. What is the ideal time of operating a congenital cataract? Number 1. And second is that about what is the ideal surgery. Okay, when you talk about the ideal time of operating the congenital cataract, let's think about something here. If the child is born and if I think, oh, he or she is a small child, why should I operate? Let me wait. Let the eye grow for around 2 years. After 2 years, I am going to operate. Is it a correct approach? No. Why? It used to be followed before, but it is not a correct approach now. Why it is so? Because the foveal reflex in a child, so let's understand this way. When the child is born, right, he cannot fix somewhere. His eyes are wandering. If you have ever noticed a newborn child, he cannot fix somewhere. Why it is so? Because his fovea is not formed properly. So what happens? Let's make a diagram to understand here that what is happening is, it's only when the light rays are falling on the fovea that this foveal reflex will be formed. So what is very important to understand that the foveal reflex formation, which is also called macula maturation. Okay, this is also called macula maturation. This occurs till 5 to 6 months of age. Okay. Now what is happening? This child has cataract. This child has cataract and therefore the light rays are not falling on the fovea. If I wait if I am not removing this cataractous lens within the critical period of 5 to 6 months, then this fovea is not going to form and the patient will develop amblyopia. What is amblyopia? I said partial loss. What do you mean by partial loss? Even with the specs correction, his vision will not come back to 6/6. That is called partial loss of vision. So, if this is not done, if I wait after 6 months, then there is a high. Therefore, we say that we should operate as soon as feasible. Why? To prevent amblyopia. Is it clear to all of you? Now, the options that they ask you, when should you operate? Okay, as soon as feasible. Then the options are immediately or after 2 months, after 3 months. This way they can give you the options. Let's understand something here. We can see this, that within 5 to 6 months is critical, correct? It starts, what time the foveal reflex formation starts? Around 1.5 months, if you want to know that also. So what happens? We always answer immediately or as soon as possible, but if you literally go into the numbers, it should be after 1 month. Why? If I do anything before 1 month, if I am going to do a surgery, the inflammation is too much and the patient will have severe inflammation and glaucoma due to inflammation of the trabecular meshwork. Okay, so trabeculitis can happen if I am too much in hurry and I am doing a surgery within 1 month. So generally it is ideally after 1 month. This is the latest concept which is given in Kansky, latest edition. But you have to understand that when we are talking about MCQs, it becomes very confusing. Please understand, even if you are operating after 1 month, it is as equal as immediately. So your answer has to be always immediately. Okay? Or as soon as feasible. But I am giving you the ideal time should be after 1 month, which is, don't please get confused, which is almost like immediately. This is how you will answer the time of operating a congenital cataract. Is it clear? Okay. And when you say this, if you are clear with this, you should also write this for yourself that before 1 month, what is going to happen is trabeculitis and this child will be at risk of developing glaucoma. Trabeculitis and developing glaucoma. Okay? That is the reason. Okay. So, whenever the options are immediately, this is equal to immediately only. Please don't get confused. Why? I have explained you. One more important thing is they can also ask you whether it is a unilateral cataract or bilateral. So, of course, unilateral is more urgency because one eye is normal. Then the amblyopia develops very deep. Okay? So, we will learn this that in unilateral, urgency is more. Okay? So, in unilateral, we will learn this that urgency will be more. You have to, because the amblyopia will be deeper and difficult to treat. Okay? Amblyopia is difficult to treat. It is deeper, developing deep amblyopia which is difficult to treat. But actually, even in bilateral, we don't answer anything else. Of course, it can be an urgency in unilateral and we should answer immediately. Bilateral, if they particularly ask you, you can say around after 1 month, that is 6 weeks. So, it all depends how the question is presented to you. Okay. So, we can say if it is a bilateral, then definitely we can, after 1 month, that is around 6 weeks, you can operate. This will only be the case when it is very, very specifically asking for these two options. Then we talk about another thing is you have operated the child and you are putting the intraocular lens, correct? Do you all remember? We will be learning this, that power of lens. How do you calculate the power? By SRK formula. We can learn it as a Shah Rukh Khan formula here. So, SRK formula which says that power is equal to A minus 2.5L minus 0.9 K. I am going to talk more in detail further. So, you know this already, right? Now, once you know this and you know that this power has to be calculated and it depends on L. L is the axial length and K is the keratometry reading which is corneal curvature reading. Okay? So we are measuring the curvature of the cornea, we are taking the axial length of the eyeball and then accordingly calculating the power. If you are operating as soon as feasible, do you realize the axial length is going to increase because the child is going to grow and the eye will grow and therefore axial length will become longer. Longer the axial length means what? More power. More power is what? Towards more power means myopic shift. So I hope you are very clear this. I will explain this in the introduction part also, that what is myopic shift means what? You have to understand is towards more power. What is hypermetropic shift? Towards lesser power. So there is a myopic shift as the child grows because the axial length is increasing. Am I clear to you all? So therefore, what is Dhani's criteria? Dhani's criteria says that if you are operating the child, just know this, if you are operating the child of less than 2 years, then whatever p-value you are calculating, undercorrect it by 20%. Undercorrect by 20%. And if the patient is between 2 to 8 years, then you undercorrect by 10%. Okay? So, this is Dhani's criteria and you should know about it. Of course, when we are talking about as soon as we are operating, we are definitely talking about less than 2 years, and in that case, we have to follow that there should be some undercorrection of less than. Undercorrection should be 20% of the total p-value. Okay? Okay. And please also know this, that maximum growth of your eyeball is till 2 years of age, but it keeps growing or changing till adolescence, right? You have to know this. That's why this Dhani's criteria. Okay, so that was about the details around congenital cataract that can be asked in exam. Now we will talk about acquired cataract. Okay, so let's talk about acquired cataract. Okay, so how do you classify an acquired cataract anatomically? Now what does it mean? Pehle ye samajh lo. It means that from wherever the area the cataractous process starts, the opacity starts, we name accordingly. Think with me. At the end, everything is going to be cataractous. So what is the difference? Everything is going, there will be opacity involving the whole lens. From where does it start? According to that, we are anatomically classifying different types of cataract. So let's make the diagram here. So this is the lens and this is the capsule, right? And if this is your cornea, this becomes the anterior. So if it is arising from anterior subcapsular area, we will call it anterior subcapsular cataract. It can be anterior cortical, make sense? Right along with me. Then involving the nucleus, this will be nuclear cataract. So this becomes your nuclear, then becomes your posterior cortical. This is your posterior cortical. This becomes your posterior subcapsular. Easy? And of course, let's not forget anterior polar cataract, starting from the anterior pole or starting from posterior pole. So these are the anatomically classified different types of cataracts. Okay, now we talk about exam question. Question is, among all, which lenticular opacity will diminish the vision most? Right? So, which lenticular opacity diminishes the vision most? Our answer is PSC. So, maximum diminution of vision occurs in posterior subcaps. Why? Why? Because it is near the nodal point of the eye. Okay, we will learn it is near the nodal point of eye. You all remember nodal point? I talked with you in the introduction chapter, if you remember. Parallel light rays bent at the cornea, bent at the lens, focus at a point just behind the lens. That is the optical center. Light rays will cross, image gets inverted, and now the same inverted image falls on the retina. Hope you remember. So this is the nodal point. Because it's near the nodal point, it will cause maximum diminution of vision. Okay, so that was the anatomical classification. According to maturity. So how do you classify according to maturity? We will classify it if some part of the lens, to start with, not all the lens is opaque, na? To start with, some part of the lens will be opaque and some part will be clear. This is what is called immature cataract. Slowly what happens? So next what will happen is the whole lens becomes opaque, right? So when slowly this whole lens will become opaque, now you will call it mature cataract. And lastly, when there are degenerative changes, okay? So if this is the lens, there is liquefaction of the cortex, there is some wrinkling of the capsule, and this is the stage, what is this? Hypermature cataract. Are we clear? So, according to maturity, the cataract can be either immature or mature or hypermature. If it is mainly a cortical cataract, it leads to hypermature Morganian, or so there can be two types. Either we are talking about Morganian cataract, or it can be after a nuclear sclerosis. This is hypermature nuclear sclerotic cataract. So, the second type becomes hypermature nuclear sclerotic cataract. Done, all of you? So, that was about your according to maturity, immature, mature and hypermature. This is a very important exam question regarding your iris shadow. So, iris shadow is seen in which state? Immature, mature or hypermature? To understand that, this is the iris, this is the lens. In the first figure what you see here, this is the, how do you understand this whole thing? Let's understand. What we are saying is, if there is a clear space between the cataractus process, which here it is shown as a central part is cataractus, and there is a clear space between, then this red line, this will be the shadow. Okay? This becomes your shadow. So, what is iris shadow? Shadow of the iris on the... So, how will you understand this? See, if you are near a wall, if you are too near a wall, you will not be able to see your shadow. But you are away from the wall, then only you can see your shadow. So, there has to be some space, some distance. Similarly here, if there is a clear area, you can see a shadow of iris on the lens. But if there is no clear area, right, like this, in this case, what is happening? There is no shadow because the whole lens is cataractus or mature. There is no clear area, so no shadow. So, this is how we understand that iris shadow is a feature of immature cataract. Okay, it is a feature of immature cataract. Right? Is it clear, all of you? Okay. Next is etiological classification. So, etiologically, we all know we can classify any cataract as senile, metabolic, complicated, toxic, traumatic, radiational, and lastly, pre-senile cataracts, which we can also say that cataract associated with systemic disease. Cataract associated with systemic disease. Right? Okay. So, first question is, which is the most common type of etiologically classified most common type of cataract? Of course, it is senile. Right? So, let's start with senile cataract. Okay. So, talking about senile cataract, we know it can be of two types. Let's write together. Senile cataract can be cortical or nuclear. Okay. So, first important thing is, it can either be cortical or it can be nuclear. Let's learn in my way. Cortical, it is due to what? You will answer the etiology of cortical. I hope you are learning along with me. We will learn is hydration of lens. I mentioned to you all, any hydration can lead to cataract. So, hydration of lens is the main cause. Whereas, when you talk about nuclear cataract, again learn along. This time the etiology of the nuclear cataract is nuclear sclerosis. Now, what is sclerosis? Sclerosis is just hardening of the nucleus, right? This hardening of the nucleus or sclerosis, what exactly is happening? Why is there hardening? So, this is important. We will understand that there is denaturation of proteins. Okay. So, there is denaturation of proteins. Now, this could either be any oxidative injury which is causing denaturation, or it could also be due to any dehydrational crisis. So, you know, sometimes recurrent diarrhea can also be a cause of cataract. This is the reason why, right? So, what exactly is happening in nuclear sclerosis is an exam question. We will learn that it is mainly decrease of soluble proteins. We already know the proteins now. And increase of insoluble proteins. Okay. Because of this, there is more of insoluble proteins. And what next is happening? If you will look at a nuclear cataract, you can see different colors, right? So, why is that happening? Because of deposition of pigments. Now, why I changed the color and wrote in red? Because this is again exam question. Which pigments? You will answer. One is your melanin and second is your urochrome. Melanin and urochrome. Got it? Okay. So, that was about your cortical and nuclear. What was cortical due to? Hydration of the lens. What is nuclear due to? Nuclear sclerosis. More of the insoluble, less of soluble. It is due to dehydrational crisis or oxidative injury to the lens, which is leading to denaturation of proteins and all these changes of nuclear sclerosis. Along with that, there's pigment deposition. Hope this is clear. Once we know this etiology, we talk about clinical features, how we learn. So in clinical features, again, we will learn like this. If I talk about the cortical part, this cortical cataract is divided into stages. So we will write together. First, there will be some clefts and vacuoles between the lamella due to the water collection out there. These clefts and vacuoles which are formed will slowly lead to, and this is going to lead to a stage of lamellar separation. Okay? And when there is a stage of lamellar separation, what will happen? That means water is there and some lamella is separated. Next stage would be your incipient stage. So, incipient stage is mainly your, when you see the radial spokes and you see some cataractous changes have started. So, the story is hydration, then little hydration causing separation of the lamella. Now, some opacification has started as peripheral corneal opacities. After that, what happens is more hydration, which can lead to swelling of lens and leading to intumescent stage. Okay, all this is what? This is immature cataract, and this immature, so the intumescent you have to just learn in between, with the next stage, third would be immature cataract. All this is coming under the category of immature cataract. What will be the fourth stage? It is mature, and fifth stage, it is hypermature cataract. Are we writing together? So, this time, what was the name of the hypermature I told you? Morganian. We now look at the stages of the cortical cataract. So, in cortical cataract, first is your lamellar separation, then comes the incipient cataract. Please note down, this is also called cuneiform. These radial spokes that you see, we also call it cuneiform cataract, right? Okay. After this cuneiform cataract, what is the next stage? Next stage is becomes immature. Of course, in between I told you there will be intumescent stage where there is maximum hydration. Opacities have started, we call it immature stage. All this is immature stage, then comes a mature. And finally, what is this? Hypermature. And hypermature will later lead to Morganian cataract. Got it? Clear? So, this hypermature Morganian is, if you will see, there is lens nucleus has sunk down, right? And there is liquefied cortex. And you must have learned this in your MBBS and remembered it also like this, that when you ask the patient to remove his head, on one side or the other, the nucleus is dancing in the liquefied cortex. So, these are the stages of cortical. So, here again you are looking at these peripheral opacities, and what did I tell you? This is what is called cuneiform cataract, or this is the radial spokes. We call it radial spokes. Okay. And later it will develop into immature, mature and hypermature. Okay. Then we talk about next is Morganian we were talking. One important question, that's why we are looking at this slide again, is what is the most common complication of Morganian? So, what is the most common complication of Morganian? Why it is important to know it? Suppose a patient says, no, I don't want to get my cataract operated. No, I am very afraid of surgery. I don't bother. I am happy with low vision and everything. But I will not get any surgery done on me. What will happen to that patient? He will develop glaucoma, which is damage of his optic nerve, and in due course, he can go blind. Right? So, this is very important. What is the most common complication of Morganian cataract? You will answer phacolytic glaucoma. So, what is phacolytic? Phacolytic, it is the leakage of lens proteins. What is happening in hypermature stage? Wrinkling of capsule, liquefaction of cortex. We have learned this. Let's draw a diagram to understand that because of all this, what is happening is there will be, if this is the wrinkling of the capsule, there is going to be leakage of lens protein into the aqueous. It is going to flow with the aqueous. What next is going to happen? It blocks the trabecular meshwork. So, here it is blocking the trabecular meshwork. And what type of glaucoma that will lead to? It is going to lead to secondary open angle glaucoma. Why secondary? Because we know the cause. Open angle means blockage of trabecular meshwork. We will talk in glaucoma chapter more in detail. Okay. So, this is your phacolytic. Now, we will talk about some other lens-induced glaucomas as well. Second is your phacotoxic. Same story, only thing you can even use that same figure here, except that T for T, this is T for T will help you to remember trauma. So think yourself common sense, any trauma means capsule rupture, and any capsule rupture means too much of protein out. So what is the story? Trauma is causing capsule rupture. This is leading to lens protein which is too much, that's why toxic. This aqueous, in the aqueous, this lens protein is then finally again blocking the trabecular meshwork and leading to secondary open angle glaucoma. It is again secondary. Take it? Okay, so that is phacotoxic. We also call it, you should know this, lens particle glaucoma. We come to the third type. The third type is phacoanaphylactic. So do you all know this lens protein, when it comes out of the capsule, it's like a foreign body to us. Okay, because it has never been exposed to our immune system. It has always been inside the capsule, right? So what is the story here? Whenever it is outside the capsule, there is immune reaction. Immune reaction is towards what? Towards this lens protein. And this immune reaction, you should note down, is towards the lens protein, is going to lead to what? I hope you're noting down. Is going to lead to release of macrophages due to the immune reaction. These macrophages will engulf the lens protein and later it will block the trabecular meshwork. It is the macrophages which are blocking the TM. We are calling it phacoanaphylactic glaucoma leading to open angle. Again, it is a secondary open angle glaucoma. Now, very important. I know what you're thinking. What about phacolytic and phacotoxic? Yes, it's an overlapping term. Every phacolytic and every phacotoxic is also phacoanaphylactic. Can we remember this? Another important question out here which I remember, they've asked you lens protein is which type of antigen. Please revise your types of antigen. We learn here that lens protein is a sequestered antigen because it is sequestered inside the capsule. We will learn it is a sequestered antigen. Okay? Okay. So that was phacoanaphylactic. What next? Phacomorphic, due to morphology of the lens. We are talking about intumescent cataract. Intumescent cataract, what did we learn? There is a lot of swelling. If it is swelling, what can happen sometimes? We will make the diagram to understand better that this swollen lens is blocking the pupil. This pupillary block is going to lead to angle. So this time it's not open angle. It is going to lead to angle closure glaucoma. Do you understand? When there is a pupillary block, what is the story? Suppose this is a pars plicator plana here. I'm only making the side. So what is happening? The aqueous is formed here, but now it cannot go into the anterior chamber or angle. It starts collecting here. It will push the iris forward. When it pushes the iris forward, it touches the cornea and the angle is all blocked. This is causing angle closure glaucoma. Right? So this is your phacomorphic. That's another lens induced. And last lens induces due to dislocation of lens, we call it phacotopic glaucoma. So phacotopic is another lens induced glaucoma. So lastly, phacotopic is due to dislocation. Mainly it is dislocation of lens. I have already explained you the difference. When the lens has some part in the patella fossa or in the pupillary area, it is subluxation. When whole lens is away from this area, it is dislocation. So it's a partial dislocation which is called subluxation. So here mainly we are talking about dislocation. Okay. So let's learn. Anterior dislocation, this is going to lead to open angle glaucoma. Posterior dislocation, it will cause angle closure glaucoma. So how do you remember which one is what? Again, you just learned with me phacomorphic. Imagine the lens is going pitched back, right? It is going to push the iris again forward and that is always going to close the angle. So learn like this, right? So these were the lens-induced glaucomas. Talking about nuclear cataract. Clinical feature, very simple. We just learned like this. Immature cataract, mature cataract, and lastly, what did you learn? Hypermature nuclear sclerotic. Hypermature nuclear sclerotic cataract. Exam question. Most common complication of hypermature nuclear sclerotic. It's a repeated question. Most common complication. We learned the most common complication Morgagni. Now we are learning for this. So for this, what will you answer? You'll answer subluxation of lens. Okay, do you know what is the most common cause of subluxation of lens? Then you should answer trauma. Okay, we'll talk in subluxation section as well. So, please remember, most common complication here is subluxation of lens. Okay, once you know this and already know I've discussed the etiology, here this is your nuclear cataract. We all know this is the corneal, which is the corneal section, and this arrow is telling you the nuclear part is cataractus. We can see the clear area also. Can you see this? This is a clear area which is not cataractus. So, this one is a clear area, but this becomes a cataractus area, which is the nucleus. And of course, this is your corneal section. I hope this is not a confusion. And what is totally outlined is the whole lens. If you will look at this, of course, we talked about pigments, and because of that, there is different color. It can either be, so it's the color grading which can be said as yellow, it can be amber, brown or black. Okay. So, according to how darker it becomes, we have graded. Now, yellow is because whenever the nucleus is yellow, there can be yellow vision, and this yellow vision is what is called, so there is some yellowishness in your vision which is called xanthopsia. Just remember this. Okay, and brunescence is brown and nigra is black, right? And this is what is nigra. This is a very, very late stage of mature nuclear sclerotic cataract. So once you know the reason, we also should understand that when we are talking about that oxidative injury is causing this denaturation of proteins, which is contributing to the cataract formation. Another important question here is about the free radical scavenger in the lens. So, what are the free radical scavengers? So, you can just start something like this, of course, vitamin E, vitamin C, glutathione reductase, catalase and superoxide dismutase. You have to know this, okay? And any anaerobic condition of the lens is definitely also preventing any. So, no oxygen involved means it is also a very big contributory factor. What was the question asked? Why are we learning this? Just remember, according to the exam question, no role of vitamin A is no role. Okay, this is what is asked and keep in mind. Right. The next thing that they ask you from nuclear cataract, which is a repeated question, is what is second sight, or you can say what is second sight of old age. So, to understand this, we have to first understand what is accommodation. So, what is accommodation? Are you all very, very clear? Let's listen to me first. When I am looking at the far distance, what is happening? I need less refractive power in my eye. Okay. So, this is one important thing that you should remember, that when I am looking far, I need lesser refractive power. My pupils may be a little larger. My lens will be flattened. Don't mug it up. Just understand. Or understand this way. When you are looking from far to near reflex, yaad hai? What are the three things happening when you look from far to near? Convergence, accommodation and meiosis. These were the three components of near reflex. Convergence, meiosis is constriction of pupil, and accommodation. What is accommodation? Because I need more power when I am looking at the near, less power when I am looking at the far. So, when I am looking at the near, the more power that I need in my eye, I am getting from this process of accommodation. I hope it's clear now. That's why, so at whatever distance I am looking at, the refractive power is adjusted accordingly in my eye. I don't even know that. This is process of accommodation. So, what is it? How does it happen? So, we will understand through, first of all, let's make our simple diagram. Okay? Pars plicata, plana, this is the lens, just make this much, we will understand. There are three steps in accommodation that we are trying to understand and learn. So, whenever I am looking from far to near, three steps are, number one is contraction of ciliary muscles. Okay, so there is contraction of ciliary muscles. So, when these ciliary muscles are going to contract, what happens? So, understand, you are looking at this section, but actually the eye is like the iris is round, ciliary body is round, and you have the suspensory ligament supporting the lens. So, when it contracts, it relaxes the zonule. So, if you understand in a circle, you will understand anything contracting like this. So, zonules that are attached, that will relax. So, relaxes the zonule, and therefore, there is mild increase in curvature of the lens. This is the third step. There is mild increase in curvature of lens. So this 1, 2, 3 is what is called accommodation. Let's have a look here. So this is an unaccommodated where the ciliary muscles are not contracting, zonules are in this position. And when the ciliary muscles here contract, right, what happens? The zonules, they are relaxed. They become relaxed, and the next thing that is happening is increased curvature of the lens. This 1, 2, 3 process is what is, and have we not learned this? More the curvature, more is the refractive power. So whatever more refractive power that I need for my near vision, I can get from this increase of curvature of the lens. Okay? So this is what is accommodation. So initially, suppose you have to understand this way and learn like this, that the unaccommodated, the radius of curvature in an unaccommodated lens, both anterior and posterior, though it doesn't look like in a diagram, don't go into it, mainly is 10 and 10. Once it is an accommodated, it becomes anterior surface is more curved. So anything more curved means radius of curvature will be less. So this becomes 6 and 10. Just remember this. Right. So once we know what is accommodation, now we have to understand what is presbyopia. So what happens after the age of 40 years? You know about first 1, 2 and 3 steps of accommodation. What happens after the age of either 40 or more than 40? Two important things. Number one, weakening of ciliary muscles. So they can't contract that well, and less elasticity of lens means it will not be able to change its shape that properly. So when this happens, then what will happen? It will not enough contract, not change the shape. So what is happening? Refractive power is not able to increase. So when I am reading, I am better like this at this distance than at this distance. So this is what? Error in accommodation due to these process, and this error in accommodation is what is called presbyopia. This error of accommodation is presbyopia. Got it? Okay. What will you do? What is the solution of this problem? This is age related, just like graying of hairs. So what we do is, you have to increase the power, use some assistance from outside to increase the power when you are looking at the near. Which is the lens which increases power? Convex lens. So I am going to use convex lens, but this convex lens, how is it different from lens used in hypermetropia? These are only for near. In hypermetropia, you have to use for all the time. So convex lens only for near, and therefore you call them near glasses, or you can call them presbyopic glasses. Got it? Okay. So this is what is presbyopia. So once you know that this is called near glass or presbyopic glass, now let's understand if by an example. I have a patient, okay, he comes to my OPD, he is 60 years old and he is using a near glass of plus 2.5 diopter spherical. I do his refraction, I give him plus 2. He is very happy. In old age, people are having so many different problems in the eye. I am so lucky, my number is also decreasing. This is what is second sight of old age. So what is second sight of old age? Improvement in near glass. Improvement in near glasses. This is what is second sight of old age. Okay? Why this is happening? Okay, so come back to your diagram. What did we draw? I'm drawing it again for you all. So if we had just discussed how the accommodation is taking place. 1, 2 and 3, right? Contraction of ciliary muscle, relaxation of zonules, and mild increase in curvature of the lens. Now what is happening? Why is this patient having improvement of near glasses? The reason is, so this second sight of old age or second sight is due to because he is developing nuclear sclerosis. Why? How does this work? Any nuclear sclerosis means hardening of the nucleus. And when there is hardening of the nucleus, what will happen? More refractive index. And if index is more, power is more. Hence, I need lesser power on my specs. This is the reason of improvement of near glasses. More index, more power. When you go towards more power, what did I teach you? What do you call it? Myopic shift. So it is a myopic shift due to more index means index myopia. There is a shift due to index myopia. I am using this term because it was in one of your options. Okay? So now you know second sight of old age is a feature of nuclear cataract or nuclear sclerosis. It is happening due to more hardening of the nucleus, and sclerosis is causing more refractive index, and this is causing more power. Hence, I need lesser power in my specs. I hope it's absolutely clear. It's a repeated question. Please make 3 Qs if you want, but it's a repeated question asked in all types of exams. Okay, so this is what is very, very important in nuclear cataract that they ask you. Okay, next we talk about subcapsular cataract. So this is the third type of senile cataract. क्या क्या हमने पढ़ा था? Senile cataract can be either cortical or nuclear, or the third one is your subcapsular. Okay, subcapsular. And subcapsular can be either anterior subcapsular or posterior. We have done this very well, isn't it? Okay, what are you now looking at? So this is the corneal section, right? The little more diffuse light it is, but this is your corneal section. Of course, this is just a light reflex, we can ignore. What we are looking at the posterior subcapsular area, this opacity. This is what is posterior subcapsular cataract. Clear? Okay, we come to the next one. When you talk about posterior subcapsular, why it is very, very important? Let's learn few important points here. Posterior subcapsular is actually due to dysplasia of E cells. Okay, it is actually due to dysplasia of the E cells, and this dysplasia of E cells is what is called Weddell cells. We call it Weddell cells, or you can also call it bladder cells. Okay, and as you can see, this PSC is a central opacity. Another important thing, and it is involving a diffuse area. So another important point, it diminishes both your day and night vision. Okay, so both diminution of, so there's both diminution of day vision as well, because it's a central opacity, and also night vision. Why? Because of scattering of light. Okay, so it also causes diminution of vision in night. In the day also, for far as well as for near particularly, you will have problem, right? So this was about diminution of vision is maximum. This was exam question. I think I've discussed this. Maximum diminution of vision is in which opacity? It is posterior subcapsular opacity. And if I talk about anterior subcapsular is due to fibrous metaplasia of the anterior epithelial cells. Okay, just remember this. This is fibrous metaplasia. We'll talk about different types of anterior subcapsular like toxic cataracts. We're talking about in atopic dermatitis. So I will be discussing this. So fibrous metaplasia of the epithelial cells. Right. That was about your subcapsular cataract. We next talk about is metabolic cataract. Metabolic cataract, first important is diabetes. What are the points we have to know in diabetes? We always learn with like this. Make the 4 arrows and let's not forget all our exam questions. Okay. First important point, diabetes, why there will be cataract in a diabetic patient. So what is the story? Too much of glucose, all the metabolic pathways are exhausted. Krebs cycle, glycolysis, pentose phosphation, and what is only left option that is left is sorbitol pathway. And this sorbitol pathway is causing sorbitol accumulation in the lens, and any sorbitol accumulation will later, because it is very hyperosmotic, it imbibes water, and this is the cause of cataract. Second question, which enzyme is responsible for this sorbitol pathway? So it is NADPH dependent. It is NADPH dependent aldose reductase. So it is NADPH dependent aldose reductase. Come to the third important question. What type of cataract? We all know snowstorm or snowflake, because opacities, I told you, na, it's all a morphological description. Opacities look like snowstorm or snowflake cataract. Okay. Another thing. Which type of diabetes this snowflake or snowstorm is more common? Now you will answer it is more common in type 1 diabetes. It is more common in type 1 diabetes. So here you are. What are you looking at? So this is your snowflake or snowstorm, where these opacities look like this. It's a morphological description. Another very important point and question asked in exam, this is an exam question, is about frequent change of presbyopic glasses, or sometimes you can just be asked frequent change of glasses. Mainly it is the presbyopic we are talking about. What are the causes? Let's learn. Very important question, okay? Double Q. So what are the causes? Number 1, early cataract. Learn with me. So what is the most commonest silly mistake you all do? Ma'am, frequent change of presbyopic glasses? Yes, diabetic cataract. No. It is early cataract, late glaucoma, and this is the way I teach, this will be easier, and diabetes. It's not diabetic cataract which is the cause. It is diabetes itself which is the cause. Which cataract is causing frequent change? We are talking about early cataract, means incipient or intumescent cataract. So when the water is less, swelling is less. When the water is more, swelling is more. More the swelling, more curvature, more power. Isn't it? So it keeps changing according to amount of the water in the lens. So early stages of cataract or early cataract. Now you got it? So incipient or mainly intumescent or incipient cataract are the earliest. Why I am teaching like early? Because there was a question. Frequent change of presbyopic glasses is an early feature of, and all these causes were given which are correct causes. So what was the catch point there? Early feature of. So early feature of puchega, it is your cataract. Early cataract, that is intumescent cataract. Okay. What is the next is late glaucoma. So we will learn here late stage of primary open angle glaucoma. Okay? This is factual, just remember this. And diabetes. Let's understand this. More sugar, hyperglycemia, that causes swelling of the lens. Again myopic shift, more curvature, more power. So we will learn like this. In hyperglycemia, there will be, in hyperglycemia, myopic shift. Okay? And if the patient is hypoglycemic, what you are going to get is hypermetropic shift. Then we learn as hypermetropic shift. Right? Okay. We come to next is galactosemia. What is galactosemia? Due to which enzyme deficiencies? We have to learn this. There are 2 enzyme deficiencies, galactokinase and GPUT, that is galactose kinase uridyl transferase. Galactophosphouridyl transferase, Right? So, what is important as in the exam? Make a Q. This is the double Q, causes oil droplet cataract is the GPUT deficiency. And what does galactokinase deficiency leads to? We will answer. It leads to lamellar cataract. Another exam question, if they ever ask you which is a reversible cataract, whose cataracts are not reversible. But if you talk about any reversibility, it is mainly galactosemia. This is another exam question. It's a reversible cataract. Good. Come to this one. So this is what is oil droplet cataract. Can you see this? Oil droplet means the opacities, they look like oil droplet. Right. Next. Calcosis. We all know what is calcosis? Copper in the eye. Now, this copper in eye can either be due to any foreign body or it could be due to Wilson's disease. We all know this. What are the features that we are supposed to know about this? 2 important exam questions. First is, what is this? We all know we are talking about Kayser-Fleischer ring or KF ring, right? So it's a golden brown ring at the limbus and it is nothing but deposition of copper. In which in layer of the cornea? We will answer Descemet's membrane. It's in the Descemet's membrane. It's important. There are many other questions on KF ring. Just have a look at this sunflower cataract first. So this is again exam question. I hope you have made a cue there. This is what is sunflower cataract, which is a feature of calcosis. Now, what are the other things in KF ring? Make a nice cue and let's learn it. So there was a question in your INI-CT that all are correct about KF ring except. So according to that, what are the facts that we have to know? Number 1. Is it reversible or irreversible? They have asked you, please answer reversible. So even if it is fading, it is reversible. Okay. Second thing is, how does it start? First superiorly, inferiorly, and then becomes a circle. So that's another, that was again in the option which was correct. starts superiorly and inferiorly. Okay, if you want to draw, this is your cornea, right? And it will start superiorly and inferiorly. Okay, then we talk about is third important thing, all patients with neurological involvement or complication will present in Wilson's disease will present with KF ring. And what was not correct, an answer of your exam was not all patients of hepatic involvement. Only around, you don't remember the percentage, it's not exact, but around, giving you an idea, 65 to 67%. So not all patients, this is very important, not all patients of hepatic involvement will present with KF ring. Okay, so this was your exam question. This was the answer of your question in the exam. And of course, I hope you know exactly the same spelling. What is Flesher's ring? Should I remind you? Flesher's ring, it was iron deposition in patients of keratoconus. You can learn it here, it will be easy. So it is nothing but, if this is your cornea, right, any conical protrusion is called keratoconus. At the base of the cone, this iron is deposited, and this deposition is what is called Flesher's ring, not Kessler-Flesher, Flesher's ring. Okay? So it's a feature of keratoconus. I'll take it in cornea chapter, but here you will know better. What is Kessler-Flesher, what is Flesher? So this is taking this feature of keratoconus. Another question, which layer iron is deposited? Always remember, iron's deposited, any surface deposition, iron is always deposited on the epithelium. तो हम क्या आंसर करेंगे? We will say it is epithelium. ठीक? Okay, so that was about this. Next, metabolic is Lewis syndrome, which is oculocerebrorenal syndrome. We are going to learn the ocular feature. What are the ocular features? Let's learn a simple way. There are some features in the lens, and the second thing is that you see is glaucoma. Some features in the lens, and second is glaucoma. So what are the features in the lens? Number one is cataract. Right? Okay. Metabolic cataract. I hope you know it's an amino acid metabolic disorder. Hai? Second would be, what is the second? It is, and of course glaucoma is happening due to, yahan likh lo, angle anomaly. Due to the angle anomaly, we are getting glaucoma. So you're getting cataract, you're getting microphakia. I have explained you, it's less than 9 diameter of the lens. And third, very, very important, asked in the exam, let's make a cue first. We are talking about posterior lenticonus. When there is a conical protrusion, but it is posterior. If this is the eye, this is the lens, we are saying posterior lenticonus. Okay? Please make the diagram. Is a feature of Lewis syndrome. Good. So, what do you look here? See, this is your posterior side, isn't it? If this is your corneal section, right? So, this becomes anterior, and this is your posterior part, and any conical protrusion, this is what is posterior lenticonus. Okay, then we also have to solve the questions around anterior lenticonus. I think now you understand. If this is the eye, anterior lenticonus means conical protrusion anteriorly, right? So, when you say anterior lenticonus, it's more like this, yeah. So, when you say anterior lenticonus, what are the points to remember? First exam question, A for A, it is seen in Alpots. Please remember, I have taught you one A for A in introduction. A scan is used for axial, and this is the second A for A, anterior lenticonus, Alport syndrome. Easy. What is Alports? We just talked in congenital cataract. It is familial hemorrhagic nephritis. Familial hemorrhagic nephritis. Another question. Anterior lenticonus is more common in males. Okay. Another question. This was like all other options are correct except wala question where about Alports it was given. It can also present as posterior lenticonus. Is it correct or not? It's correct. Okay. So, Alports can present as both anterior and posterior lenticonus. But the point is, this is much, much more common, therefore we learn this. For posterior, we will first answer Lewis syndrome. But yes, both can be present. In this case, we will learn can be present. Where here, this is most common presentation. I think now it's clear. Okay, so these are the questions around anterior lenticonus. One more thing. Is there any other syndrome you would like to learn where you get anterior lenticonus? Yes, it is Waardenburg syndrome. The next after Welpot's is Waardenburg syndrome. Do you remember Waardenburg's? Anything systemic features you remember? White frontal locks where the hairs become white, joint eyebrows, sinophrys, vestibular dysfunction. Just revise it. I will be writing here the ocular features of Waardenburg. If I talk about ocular features, one is your poliosis. What is poliosis? It is graying of poliosis. Is graying of eyelashes. Second you will get is telecanthus. That is far apart medial canthus is telecanthus. When the two medial canthus are far apart. What is the third one? Third you are going to get is heterochromia iridis. What is heterochromia iridis? Difference of iris color between the two eyes. And lastly, of course, we just learned anterior lenticonus. So very quickly we have learned the ocular features of Waardenburg as well. Right? Remember this. Okay? So once you know this, another important question which has been your exam question is regarding what is the difference between when you say far apart medial canthus. Write with me like this. Far apart medial canthus, when you are talking about these, there are two terms related to far apart medial canthus. First, we have just read is telecanthus. What is telecanthus? We said telecanthus means when the two, this is far apart, agreed, but why it is happening? Due to soft tissue problem. So, due to the soft tissue means there is long medial canthal ligament. That is why you are getting telecanthus. So, telecanthus is due to soft tissue problem and therefore the interpupillary distance is normal. This is important. Okay. IPD normal. Center of pupil of one eye and the other, what is the distance? This is normal. When we are talking about what is the second term, it is hyperteliorism. Hyperteliorism is bony defect. You understand? When suppose, think with me, the two medial walls of the two orbits are far apart. There is a broad nasal bridge. What is this? This is your bony defect. And bony defect will lead, what will happen? There is increased interpupillary distance. So, increased interpupillary distance. Right? Okay. So, more IPD, it is hyperteliorism, it's a bony defect. Normal IPD, soft tissue problem, this is telecanthus. I hope it's clear. Let's have a look at this one. So, this is what? Look at this. This is your anterior lenticonus. Can you see this? Conical protrusion anterior. Why I am saying anteriorly? This is the corneal section. So, naturally, this is the anterior part. Okay. What are you looking at here? When I am looking, did I not talk about retroillumination where the two eyepieces will live and the illumination both are in the straight line? Can I see the red reflex here? Yes. So, I know this has been seen in retroillumination because when you are looking through retroillumination view, then you will see this red fundus glow behind. Okay. So, in this what I am seeing, can you see this circle? This is what is oil because of the conical protrusion. This feature is what is called oil globule reflex. Okay. So, it's important exam question. It's a feature of anterior lenticonus. Oil globule reflex is seen in anterior lenticonus. Right. Then we talk about some more oils in ophthalmology. I talked about oil droplet cataract and galactosemia. I am saying oil globule reflex in lenticonus. So, what are the other oils? So, let's learn all the oils here. First was oil droplet cataract, galactosemia, oil globule reflex. Third is oil droplet reflex. What is oil droplet reflex? Oil droplet reflex is seen in keratoconus and it's a finding on not direct, please correct this, distant direct. It is distant direct ophthalmoscopy. In distant direct ophthalmoscopy, right? So, when you say distant direct means, you understand, no? Direct ophthalmoscopy is taken very close to the eye and seen. That is your direct. When you see it at distance, that is called distant direct ophthalmoscopy. So, this is what is oil droplet reflex. Again, we'll have a look in the cornea chapter as well. And everything is exam question. That's the interesting part. I will say again a repeated question. This is one, this is again repeated question. Right? So they ask you, this is all important. We next talk about after metabolic, what is this type of cataract? This is your complicated cataract. Can you all please give the heading complicated cataract? Okay, what you're looking at is breadcrumb appearance, which is typical of complicated. And secondly, if you can see, there are different colors. So this is important. Complicated cataract is, what is the pathognomic feature? One question. You will answer, pathognomic feature is polychromatic luster. Poly means multiple, chromatic means color. So, multiple colors can be seen. This is polychromatic luster. Right? Okay, this is your complicated cataract. Number one question. Second question is, what is the most common type of complicated? We answer, posterior subcapsular. It is posterior subcapsular. So, you understand why it is called complicated? Because this cataract is occurring as a complication to any anterior segment disease or posterior segment disease. Okay? This is why we are calling it complicated cataract. Okay. So, now talking about, it could be anterior segment. Most commonly, it is chronic anterior uveitis. We'll talk more in the uveitis chapter. You can see the posterior synechia. You can see the cataract behind. This is the light reflex, of course, but this is the cataract behind this one. So, generally, commonly, it is a PSC. And this is a chronic anterior uveitis. So, what you see here is, this is one of the most common causes of anterior segment disease causes, which is leading to complicated cataract. Okay. Then talking about what are the other causes. So, one is anterior segment and one is posterior segment disease. Anterior segment, we talked about chronic anterior uveitis. These are the posterior segment causes. Okay. So, it can be high myopia, hereditary fundus dystrophies like retinitis pigmentosa, Leber's, gyrate atrophy and Stickler syndrome. Right? Okay. So, these are some of the causes. We will talk about most common and important ones, right? Okay. What is Stickler syndrome? If you don't remember, this is your collagen disorder. Collagen production disorder, and most common ocular feature of Stickler is retinal detachment. We'll talk about more in subluxation of lens as well. So, these can be the causes of complicated cataract. Let's talk about toxic cataract. So, toxic cataract means due to drugs. So, any medicine the patient is eating and because of that he is getting cataract. This is what is toxic cataract. What are the drugs? First is your steroids, very important. Second, phenothiazines. Third, long-acting miotics, right? Then, amiodarone, busulfan, chloroquine and gold, right? So, this is the list you have to know. Why I have written two colors? Let's understand. Of course, first theme you should take is for steroids and second for phenothiazines. That's why I have written this way. Not everything is in sequence to be learned, but yes, 1 and 2 are. After this comes the rest of the causes of toxic cataract. So, the one which are in the black, why in black? Because these three are the ones which cause posterior subcapsular. Whereas, rest are causing, we have learned this, anterior subcapsular cataracts. Okay, the rest can cause anterior subcapsular cataract. I think it's a very, very famous and common mnemonic that we learn here. And what is that? That BSC causes PSC. What is BSC? It is busulfan, then this is steroids and chloroquine, right? So, BSC causes PSC. This will help you to retain. Okay, another exam question. Okay, another exam question is, what is the most common complication of steroids in eye? If they ask you this, should you answer cataract? No. Most common complication we'll answer is glaucoma. Which glaucoma? That was your next question in the next exam. Which glaucoma? It is always open angle glaucoma. I've taught you, open angle means there's blockage in trabecular meshwork. So, what actually is happening which is causing blockage in the trabecular meshwork? It is deposition of mucopolysaccharides. It is deposition of mucopolysaccharides in the trabecular meshwork. Okay, next question. What is more common after systemic steroid? What is more common after topical? So we will learn after topical more common is glaucoma. After systemic more common is cataract. Which cataract? I just taught you PSC, posterior subcapsular. This also asked, right? Okay, so next we talk about is traumatic cataract. Traumatic cataract. So trauma, keep in mind, we have to talk about perforating injuries, blunt trauma, and third would be electric cataract. So we have three headings to think of. One is your electric cataract. We'll talk about it. Then we will talk about blunt trauma. What is blunt trauma? Also known as concussion injury, right? And perforating injury. Perforating, just understand, if this perforating injury is hitting the lens, it will cause cataract. As simple as this. Nothing more is asked. We are going to learn more in uveitis chapter when we discuss about sympathetic ophthalmitis. We are mainly focusing on learning about blunt trauma, that is your concussion injury. Any blunt trauma or concussion injury, what are the features? If there is this injury in the eye, what are the features? What are the findings? Very, very important. We again make these arrows and everything is your exam question. One by one. First is your rosette cataract. Which cataract? Rosette shaped cataract. We'll take it one by one. Second finding, when there is a trauma like this, like the impact like this, the iris touches the lens. The posterior surface of iris has pigments. That gets stuck or imprinted on the lens. This is on the anterior capsule of lens. This is called Vossius ring. I'll just show you the slides shortly. I'm just listing it as of now. Third, of course, there can be edema at the macula, which is called Berlin's edema. And fourth is your disinsertion of iris, iridodialysis can happen. There can be other changes in blunt trauma like hyphema, that can also happen. And of course, we'll learn in injuries chapter again. And lastly, we will not forget angle recession glaucoma due to tear in the ciliary body. The angle which was like this is now more behind, piche chala gaya, recession. So, if the angle was like this, now the angle is like this, something like this. We'll learn again in detail in glaucoma chapter. Just note down here, angle recession glaucoma. It happens due to recession, matlab to go behind. This is due to tear in the ciliary body. These are some headings which you have to know for your exams, and these are important features of blunt trauma, right? Okay, one by one. What are you looking at? So again, this is the corneal section, right? If this is the cornea, this becomes your anterior part. And what do you see when the light is reaching the lens? This traumatic cataract, this is what is rosette shape. Okay, can you see this? Typical opacity rosette shape. Now there's a question. It starts from, another question is, it starts from which part of the lens? You will answer, it starts from posterior cortex. It starts from posterior cortex. Okay, so that is rosette shape. What are you now looking at? Can you see this? This is disinsertion. Can you see this? Disinsertion. This is what is iridodialysis. And when there is iridodialysis, what is the shape of pupil? Is your exam question again. We answer D-shaped pupil. Can you see that? D-shaped pupil. It is outlined for you. It's a feature of iridodialysis. What is iridodialysis? This one, the arrow that I have shown you. This is iridodialysis. That is disinsertion of iris. Okay, next, what is this? So we see an imprint of iris on where? What is anteriormost part of the lens? Anterior capsule. So this is asked. Vossius ring is what? Imprint of iris pigments. Where? On the anterior capsule of lens. Okay, so this is what you're looking at as Vossius ring, right? So now you can see this Vossius ring in a section. So here, if this is the anterior part, this is the corneal slit. When the light is reaching the lens, so this is what is Vossius ring, right? Can you see that? This is nothing but iris pigments are all deposited on the anterior capsule of the lens, right? Let's see the next slide. Okay, so what do you see next? What I see is a red spot on the macula and some edematous area Of course, the color of disc is little wrongly depicted, and if it is actually so, then it's going towards a trophy, isn't it? Anyway, normally we see a normal color of the disc. And what is this condition known as? This is commotion-retiny. Commotion-retiny is nothing but other name of Berlin's edema, which is also, and I think you remember this, you used to get short notes on commotion-retiny, right? So this is important. In the MBBS also, we have written so much on commotion-retiny, and it presents as cherry red spot and the macula. As of now, we'll learn this. Details of cherry red spot we will discuss in the retina chapter. Okay, so these were the features of blunt trauma or traumatic cataract. And the third type which we have learnt is electric cataract. Can you see this? These are stellate opacities, and these are typically of look of electric cataract, and they are anterior subcapsular. Don't forget this. They are anterior subcapsular. What is the next type of etiologically classified cataract? Is radiational cataract. All electromagnetic radiations can lead to cataract. Keep in mind. So radiational cataract, there's one interesting question. Of course, one important question is this one. Let's first see to this one. Most common type of radiational, if they ask you, you answer PSC. Apart from this, they have asked you about glass blowers cataract. People working in the glass factory are exposed to infrared radiations, and they can get either cortical changes or PSC. This is glass blowers cataract. We will keep this in mind. It is due to infrared radiation. Another thing is, they have asked you, will you get a radiational cataract after CT scan? Yes, I can. It's an electromagnetic radiation. What about after MRI? No, MRI is not electromagnetic. We don't get any radiational cataract after MRI. So these are some questions around radiational cataract. Okay, once we are talking about radiational cataract, another thing they can ask you is about the radio-resistant and radio-sensitive structures. So if I talk about the whole eye, this is important question, whole eye, then the most radio-resistant structure, what is that? This is exam question. And most radio-sensitive is what? So let's learn together. When you're talking about most radio-sensitive, the answer is lens. And most radio-resistant, now the answer would be most radio-resistant, you will answer is, which is the thickest, strongest structure that you can see in the eye? It is sclera. Okay. They've also asked you for retina. I can discuss in the retina chapter, but because I'm remembering it, let me discuss here as well. So they've asked you for the retina, what is the most radio-resistant and most radio-sensitive? Say this is asked most radio-resistant layer of the, we are talking about layers of retina here. So resistant layer of the retina. And what is the most? There are 10 layers of the retina, you remember that. So we are talking about that only. And what is most radio-sensitive? So most radio-resistant, if they ask you, what should be your answer? You will answer ganglion cell layer. Okay? Ganglion cell layer. And most radio-sensitive, the answer is photoreceptor layers, rods and cones. Right? Okay, so these were some important exam questions around this topic. So this is what are you looking at? This is your glass blowers cataract. Okay, all these opacities that you see, this is what is glass blowers cataract due to infrared radiation. Okay, so if you have just learning about the different types of cataract, did you realize there are so many questions around PSC? Let's quickly just list it out again. So if we talk about posterior subcapsular cataract, first question was maximum diminution of vision occurs due to PSC. And what did we learn? Why? Because it is near the nodal point of the eye. What was the second question? It is the most common type of complicated cataract. Right? Okay, what is the third question? It is the most common type of radiational cataract. Very good. And what is the next question? Next question we have learnt is that steroids cause, so we can learn PSC causes, BSC cause PSC. Mainly they have asked for steroids, it is again PSC. So these are some important questions on PSC, it should be on your tips. Right. What is the next type of cataract that we have to learn? Is pre-senile cataract. Pre-senile means before old age, that is before age of 50 years. So pre-senile cataract, one is diabetes, that can happen. What is the second one? Myotonic dystrophy. Everybody knows it's a myopathy, right? So, what do you get in myotonic dystrophy? Can you see these needle-like opacities? This is what is Christmas tree cataract. Okay, so these are the Christmas tree cataract. So, when you say Christmas tree cataract and myotonic dystrophy, the next thing that you have to learn here are the ocular features. So, what are the other ocular features of myotonic dystrophy apart from this Christmas tree cataract? Please, all of you, Christmas tree cataract is exam question. I hope you know this. I had mentioned earlier as well. Okay, so to learn this, let's again learn my style. We make an eye diagram, simple one. And here again, this is picetta plana, this is the lens, suspensory ligaments, right? Okay, and this is your choroid, and this one dotted line is the retina. Simple. Now, what we have to learn is what are the other ocular features of myotonic dystrophy. Interestingly, we learn it as 5 Ps. So, what are these 5 Ps here? First, outside twin, if you think on the lids, there is ptosis. Okay, 1 P. That is drooping of the eyelid. Second P is presenile cataract. And this presenile is what is called Christmas tree cataract. Exam question, Christmas tree cataract. You just saw Christmas tree, the needle-like opacities. What is the third? Low intraocular pressure. Okay, so we can say decreased intraocular pressure. One is cataract, one is ptosis. These are the 3 Ps. Another P was pressure. Another P is pupil is miotic. So, we can write here miotic pupil, slowly reacting. And last P is pigmentary retinopathy. Pigmentary retinopathy. So, if you just remember your diagram, you will never forget the different features and the 5 Ps of myotonic dystrophy. Right? And what did we learn? That this is what is, again showing you, this is what is Christmas tree cataract. Right? Okay. It's an important question. Coming to what is the next presenile is this one. What is this? Can you see the cataractous opacity is almost like shielding the pupillary wall. This is what is called shield cataract. It's a feature of atopic dermatitis. And we are going to also learn about shield ulcer that we see in vernal keratoconjunctivitis. In the conjunctiva chapter, we are going to take that. Okay. So, just remember, just to keep in mind and to be easier, it's easier to remember, we have to learn one shield ulcer and one is shield cataract. Right. Now, let's talk about the clinical features. How will a patient of cataract present? It's common sense. There's an opacity which is hindering the light rays. I already explained. So, what will happen first? Blurring of vision. Right. So, first of all, what you can get is blurring of vision, which can later lead to diminution of it. Okay, just 1 minute. First, we should write blurring. So, first is your blurring of vision, right, all of you? And this will later lead to diminution of vision. Let's think one by one. When we were talking about the different types of cataract, if it is a cortical cataract, right, in that case, it is the diminution of vision is going to be more in the daytime, right? I'm so sorry, more at night, right? Because the pupils are dilated. So, this will be difficulties more at night. Whereas, when we talk about the nuclear cataract, because it's at the center, pupils are constricted during the daytime. So, you get more at daytime, in the daytime. And it can sometimes also be a cause of day blindness or hemerotopia. Right, all of you? So, we will keep this in mind. And what did we learn about posterior subcapsular? We learned that in posterior subcapsular cataracts, we learned that they can be both day and night vision, both are affected. We have discussed this already. Okay? Yeah. What is the next thing that can happen is glare. The patient can complain of glare, especially while driving at night. He can complain of polyopia. What is polyopia? Multiple images. More than 2 images is polyopia. It is generally seen in, you will answer, incipient cataract or in intumescent cataract. In this stage, you can get multiple images or polyopia. So, there was an exam question, both were given as an option. In that case, we will first answer incipient cataract. We prefer to answer this. And lastly, very important, asked in the exam is colored halos. So colored halos are nothing but breaking of the white light. When the patient is looking at the light, you see colored rings around the white light. This is what is colored halos. Okay, so what are the causes of colored halos? So when we talk about the causes of colored halos, let's learn like this. Colored halos can be either due to, number one, that you've just learning with me, that is your cataract. Which cataract? Of course, I should be able to see something na, to appreciate the halos. So it cannot be a mature cataract. We are talking about immature cataract, right? So immature cataract. What is the second? Second cause would be glaucoma. Should I say glaucoma? I get a 0. Because glaucoma is a very broad term. It's something like, I'm asking you where you live. Oh, I live in India. I don't reach anywhere. Isn't it? So, what should I answer? Specifically, we have to answer acute congestive glaucoma. Okay. Acute congestive glaucoma. What do you call acute congestive? We also call, the new name is acute primary angle closure. We'll talk about details of glaucoma in the glaucoma chapter. And what is the third? The third that you will learn with me is, please don't answer again, conjunctivitis. You have to tell which conjunctivitis. So if there is a watery discharge, you won't see colored halos. You are seeing colored halos only when it is mucopurulent discharge. So you will answer mucopurulent conjunctivitis. So we answer mucopurulent conjunctivitis, right? Because when there's too much of discharge, it's like having a lot of ointment in the eye. So what will happen? There's a diffraction of light and this is going to lead to colored halos. And why acute congestive glaucoma is very important to mention? There's a reason. Because it is only in this stage that the pressure goes to above, equal to around, we'll say around 60 millimeters of mercury. This is a very high pressure. And when the intraocular pressure exceeds more than the stromal pressure of the cornea. Okay, what is the stromal pressure of cornea? You will answer it is around 53 to 55 millimeters of mercury. So when it is more, it leads to corneal edema. And it is this corneal edema which is the cause of colored halos. Okay. Because of this corneal edema, what you get is colored halos. So this is the main mechanism or reason why you're getting colored halos. Right, all of you? Okay. So next thing that they can ask you, this is an important exam question, is what is Fincham's test? So what is Fincham's test? When you have to differentiate between the colored halos of acute congestive glaucoma from that of cataract. Of course, you can do it. You know, in the patient, you can always find out whether he has cataract or acute congestive glaucoma. But yes, this test is important. Let's see. They ask you in the exam, this is a stenopic slit. You all know what is a stenopic slit. When you go for an eye test, you see the refraction box. You see different white lenses, which are the plus ones, golden ones are the minus ones. Then you know what is a pinhole. It's a black. If there is no opening, it's an occluder. When there's a small hole, this is pinhole. Similarly, when there's a long slit, this is called stenopic slit. So when you pass this stenopic slit in front of the patient's pupil, if the halos he is looking at is breaking, something like this. So this is the pupil in the round, that circle, black circle, and the slit is being passed. Once he's seeing the halo like this, then it becomes like this, right? Then it is again becoming like this, right? So this is breaking of the halos. Right? And when you passing, it is just changing, make and break. Then it is, so if halos break, we are saying this is cataract. Okay? Not break, it's all uniform. If this picture was not there, then it is due to acute primary angle closure. Just remember this. Right? So this is what is Fincham's test. Because in acute primary angle closure, it's a uniform corneal edema which is causing the colored halos. But when we talk about immature cataract, somewhere there is an opacity, somewhere it is clear. So there's an interruption. So you generally see a make and break of the halos. Right. Okay, so we were talking about diminution of vision, and I hope you want to mention this. What are you looking at? As you know, is the Snellen's visual acuity chart. Of course, we'll discuss the details in the optics chapter. What are you seeing anyway? What we are seeing here, These are the different visual acuities. Let's understand some basics of Snellen's acuity chart. When do you call it diminution of vision? So I just want you to know, when do we call it diminution of vision? Normal vision is generally considered 6 by 6. So do you want to understand when you say 6 by 6, 6 by 9, 6 by 12, which is normal, denominator or numerator? It is the denominator. When I am saying 6 by 18, what I mean to say that this size letter OLAF, a normal person can read from 18 meters, which your patient is only reading it from 6 meters. When I say 6 by 24, a normal person can read from 24 meters, which your patient is only reading at 6. So the denominator is the normal, right? And when it is 6 by 6, we call it a normal vision. Anything less than 6 by 6 is diminution of vision. Got it? So this is what is diminution. You will learn one more term. Why I am specifying this? You may be thinking, why I am discussing diminution. Of course, we all know what is diminution. Because there is another term, disturbance of vision. Now, what is disturbance of vision? We will learn it in retina chapter when we are talking about central serous retinopathy. As of now, just understand what is diminution of vision. Okay. So, once we know about the clinical features and these points, our next heading would be how to treat a cataract. Right? Do we have any medicine to manage cataract? No. Any medicine for prevention? Again, a big no. So, the only option is surgery. Okay. So, here we are going to learn the different surgeries that we do for cataract. If I want to list out with you all what are the different surgeries, just listing out, details will take one by one. One is your ICCE, intracapsular cataract extraction. Second is extracapsular cataract extraction with posterior chamber intraocular lens implantation. What is the third one? Small incision cataract surgery, which can be either a manual cataract surgery or it is phacoemulsification, right? And fourth one, which is the latest, is femto laser assisted cataract surgery, right? So before I go to all this, right? So once you know the different types of cataract surgeries, of course we are going to take each and every type in detail. Of course, before the surgery we give anesthesia. So what is the local anesthesia and what are the different ways you can give? We have to know this. So majority of the times if I am doing a phacoemulsification, I am in a small, of course it all depends whether your patient is cooperative or not. We can generally prefer topical, right? When you give topical, remember the akinesia is not gone. That means the patient can still move his eyes. It's only the pain which is gone. And what drug we give? It is proparacaine. Number one. Number two, what you can go for is peribulbar injection. Number three, retrobulbar injection. And of course, intracameral, that is inside the anterior chamber, which is a preservative-free intracameral, can also be just put during the surgery. When if there is any problem, you can give the drug intracameral. If you are giving intracameral, I just said inside the anterior chamber, it has to be preservative-free drug. Otherwise, it is going to damage your corneal endothelium. That is why it should be preservative-free. Alright? What is peribulbar and retrobulbar? Now, let's see what is peribulbar and what is retrobulbar anesthesia. So, peribulbar, you know this is the eye wall, this is your optic nerve inside the orbit, right? So, when you are giving the injection outside the muscle cone. So, this is the muscle attached. As you can see in red, these are all the extraocular muscles attached. This is your optic nerve, right? Right? So, this space which is here, this is called intraconal space, okay? And this space which is outside, this is called extraconal space. So, what we are learning here that peribulbar is given in extraconal and this is retrobulbar which is given in intraconal space. And do you realize that means there is always a risk of optic nerve damage in retrobulbar anesthesia. So, we have to keep this in mind, okay? If we like to compare, we have to know the comparison between peribulbar and retrobulbar. Apart from the space that we are giving, of course, the needle has to be longer in case of the retrobulbar compared to the peribulbar. We have to keep this in mind, right? Now, what are the drugs that we give? This is also important exam question recently asked. One, of course, is lidocaine. Lidocaine, lignocaine, xylocaine, it's all same. So, we give lidocaine or lignocaine. Bupivacaine is helping to sustain 0.75%. It is given to sustain the effect And hyaluronidase is given so that there is a better spread of the tissue, which can be with or without epinephrine or adrenaline. Okay. So these things have to be kept in mind. And of course, how do you give it in this anesthesia? One is between the lateral 2/3 and medial 1/3. Right? Medial 1/3. You take the junction of the two, and here we are putting the injection. We are talking about either of the injections we generally give here, and the second one is given at the supraorbital notch. This much is enough for the anesthesia part that you have to know. After this, we talk about the different surgeries. Okay, we start with the different surgeries. First I said was ICCE. This stands for intracapsular cataract extraction. When you say ICCE, it is including the capsule and removing the lens. Definitely we don't want to do the surgery now. We need that capsule to put the artificial intraocular lens. But yes, what are the important things we have to know about this? So when you say ICCE, where you're removing whole capsule and the lens, first thing is let's understand how we go about it. If this is the dilated pupil, this is the 12 o'clock of the patient and this is the 6 o'clock. I'm sitting at the 12 o'clock, that is behind the head end. Now what we do, we give a large section from 3 to 9, this big full thickness cut on the limbus. Then we hold the lens, go for sideways movement to break the suspensory ligament and slowly take it out. So how we hold the lens, according to that, there are different types of ICC. One is your forceps extraction, different types of methods of ICC, I should say. One is forceps extraction. In forceps extraction, we are using Aruga's forceps to hold the lens and remove it. What is the second one? Cryo extraction. I am using a cryo probe. What is the third one? I can go for a spoon-like instrument like this. This is called wire vectis. So it becomes wire vectis method. And what is the fourth one is, I'm not using any instrument. I give a pressure at the 12 o'clock, the 6 o'clock, 12 o'clock, 6 o'clock with pressure, counter pressure. This is called Indian Smith method. Correct? Okay, so these are the methods of ICC. Now, question is, which is the best method? Best method you will answer is cryo. Okay, so the best method is cryo. This is your exam question. There are two more questions they ask you in ICC. We know that, see here, what are you looking at here? This is what is cryo extraction. This is a cryo probe and we are looking at cryo extraction. The second question is, of course, I don't want to do the surgery. So the second question is, what is the only indication of surgery today? Only indication of removing the capsule is when you can't save the capsule. So the only indication of ICC you will answer is subluxation of lens. It is subluxation of lens. Right? Okay. Come to the next question. Next point they can ask you is, ICC is contraindicated in children. So this is another point they ask you, why it is contraindicated in children. So let's understand. We'll make a diagram again. We'll understand in my style. So if this is your eye and here you are, very quick one. This is lens, suspensory ligaments and this is this. Right. Now what we have to understand here, that in childhood, I taught you what is the anterior hyaloid membrane. It is a condensed part of the vitreous, right? So this is the condensed part of the vitreous. This is called hyaloid membrane. In our childhood, we have a strong adhesion between the lens and the anterior hyaloid membrane. And this is what is called Wegert's ligament, or we can also call it hyaludocapsular, because this is a posterior capsule and there is attachment with the anterior hyaloid membrane. So it is called hyaludocapsular ligament. So we call it hyaludocapsular ligament. Correct? So this is Wegert's ligament or hyaludocapsular ligament. Okay. Because it is a very strong adhesion, if I do ICC, I'll remove the whole capsule, I'll pull on the vitreous. And any pull on the vitreous is a very big risk of retinal detachment. And this is the reason we don't pull the vitreous, we only cut the vitreous. And in adulthood, what happens? This will loosen out. It won't be such a strong adhesion. Therefore, it is not causing any problem. And hence, ICC is contraindicated in children. Got it? Okay. We come to the next. Okay. Look at this slide also. So, this one is your Ruga's forceps. And this is what is wire vectis. So, the next surgery is ECC with PCIOL. This is extracapsular cataract extraction. So what we are doing, making a big incision, removing the cataractus lens, and what we are doing, this is the intraocular lens which we are putting inside the eye, right? So this is replacing the cataractus lens with the intraocular lens. This is what is ECC with PCIOL. How can you do that? We don't remove the capsule. What are we doing? Let's see. So what we are doing is, this is the dilated pupil. Now this is again 12 o'clock and 6 o'clock. This time my incision is little bit smaller than the ICC, about 10 to 2, right? And after giving this incision, what I have done? I have just, what about the ICC? I think I didn't complete the whole process which I was teaching you, that if this is the dilated pupil, this is 12 o'clock, 6 o'clock, we gave an incision from 3 to 9, hold the lens, sideways movement, remove the lens, and of course I should complete this, that we will give radial sutures to close the section. Okay, so this one was ICC. We have learned 3 points in ICC already. It is contraindicated in children. We generally do it in subluxation of the lens, and best method is cryo. This is done. Now coming back to ECC, which I was trying to discuss here. In ECC with PCIOL, if this is the dilated pupil, again 12 o'clock and 6 o'clock. Now what you do, you give incision which is little smaller, 10 to 2. Again, it's a full thickness cut. I have to save the capsule. So what I now do is, I give a incision which are multiple cuts on the anterior capsule. This is what is called anterior capsulotomy. So once I have done the anterior capsulotomy, now what next? Once this is done, I will inject water under the capsule and separate the capsule from the whole lens. Once I have done this, with pressure counter pressure, I remove the lens, clean the bag with irrigation aspiration cannula, and put the artificial intraocular lens on inside the capsular bag, and later suture the section with radial suture. Got it? So this time I am saving the capsule, right? We'll keep this in mind. Should I repeat the steps very quickly? After anterior capsulotomy, hydrodissection, sometimes also delineation. What is delineation? When you are into the substance of the lens, separating the nucleus from the epinucleus. What is dissection? Separating the capsule from the whole lens. After that, with pressure counter pressure, because the section is open, I take out the nucleus, then clean the bag and put the intraocular lens, and then suture the section with radial sutures. This is what is ECC with PCIOL. Right. So once we know this, why are we always putting radial sutures is what I want to discuss in both the cases, in this also and in this also. Why are we putting radial sutures? Because this will cause minute. Can you imagine? You're cutting, then you're stitching. You are definitely altering the corneal curvature. But with this, ideal suturing is equilength, like in this one, equilength, okay, equidistance, and radial. What is radial means? The direction is such that when you draw an imaginary line, it is passing through center of the pupil. So it is radial sutures. Why radial? For minimum post-operative astigmatism, because the post-operative astigmatism will be minimum. Minimum or whatever it has to, this is the way we could minimize if I am talking about a surgery with sutures. Right. I hope it is clear. Okay, so what is the other method of doing an anterior capsulotomy is, one was this multiple cuts. What is this called? This is your can opener. Second you will say is, I just give a single nick like this, like an envelope. Do all the surgery, remove the cataractus lens, post the intraocular lens after cleaning the bag. Later I am extending this incision. This one is called envelope technique. It will ensure that my lens is always in the bag. So this is envelope. These are what? Techniques of what? Anterior capsulotomy. Okay, this is anterior capsulotomy. And what is the last one, which is the ideal one, which we are doing in a small incision cataract surgery also? That is your CCC. Okay. So what is CCC? When you create a round, smooth opening like this. This is your continuous curvilinear capsulorhexis. Okay. So we'll know this. Continuous curvilinear capsulorhexis. Right. So that was about your 3 types of anterior capsulotomy. What is that? Do you have any idea how to do this capsulorhexis? So if this is the capsule, you just give one nick, little straight line, one single cut. Don't go too far, otherwise it will extend on the posterior capsule. Just a small nick, hold it and slowly tear it. Okay, so that will create a uniform opening. We'll see the video also. Okay, so what you are looking out here is the section, that is incision at the limbus 10 to 2 at 10 to 2. Okay, so this is your ECC with PCIUL. So I think you have understood how much of the capsule I am leaving behind. If you've understood the surgery, little bit of anterior and whole of posterior. Okay, and this little bit of peripheral part of the anterior capsule and whole of the posterior capsule, this is me. I'm only cutting at the center, and this is what is called capsular bag. And the whole summary here is, inside this capsular bag, I am going to put the intraocular lens. Okay. And if you see, I am making the intraocular lens with, this is the optics of the lens, and this is the supporting part is called haptics. This is another point to remember. This is haptics and this is optics. If I talk about the non-foldable lenses, the question is, what is it made up of? You will answer PMMA. It is made up of polymethyl methacrylate. Right, all of you? Okay. So, we will understand a little better what is hydrodissection. What did I say? Injecting the water just below the capsule. Right? So, look at here. If this is hydrodissection, where this is the capsule and now the water is injected just below the capsule to separate the lens from the capsule. This is what is hydrodissection. What is hydrodelineation? This time my water injection is around the nucleus. Huh? So, this is your hydrodelineation, where the water is injected just outside the nucleus, separating the nucleus from epinucleus. Right. What is the next surgery is small incision cataract surgery. What are the features? First, incision is small as the name suggests, and very, very important, these are sutureless surgeries. We have two types. One is manual. Please learn, it is 5 to 6 millimeter incision length. Phacoemulsification is 2.75 to 3.2. You can easily learn it as 0.3 se 3.25. Okay, so this is exam question. Why are we so much worried about sutureless and giving smaller? Why can't my life be easy to open nicely and do the surgery and then stitch it? Why do I have to open very less and expertise in not cutting too much, not suturing also? This is because that if this is the cornea and I am not cutting, I am cutting very less, very small incision, I am not suturing, there is negligible or no post-op astigmatism. I would say negligible or no post-op. This is the biggest benefit why I am doing this surgery. Let's keep this in mind, right? Okay. So, one by one. When you do a manual, what do you do? See, whenever I have to give a full thickness cut, I'll have to stitch it. Now, my aim is not to use sutures. So, what I do, behind the limbus, which is, let's draw together here, if this is the dilated pupil, right, what I do, 1 to 2 millimeter behind the limbus around here, I give a partial thickness cut on the sclera. So, what happens, I reach some depth, now I move into that depth further till I reach this anterior chamber and then I enter. So, actually I am at 3 planes. First plane was when I made the first cut. This is my external wound. Then I dissected further from here to here. This is my second plane. When I entered the anterior chamber, this is the third plane. And because I am starting from the sclera, this is called scleral tunnel formation. So, this is your scleral tunnel formation, right? And these are triplanar. So, I have just shown you a straight incision, but we can also have incision something like this, frown shape. This will minimize the astigmatism. I cannot go too much in detail, that's more of a PG level, but yes, you should know this. That what is scleral tunnel. So, this is the scleral tunnel which is made, which is behind the limbus, 1 to 2 millimeter behind the limbus. When you are making this tunnel, scleral tunnel, we are ensuring I don't need any suture and my incision is very small. When I am going inside and I am entering the anterior chamber, now I increase the space of my tunnel, so that when I am removing the nuclear parts, it doesn't tear away the tissue. Okay. So, let's see this. So, if you will understand here, if the outer length was 5.5 to 6 millimeters, the inner one becomes 6 to 7. So, it's in this shape that I want to, so that if I dissect further here peripherally, when I am removing the nucleus, I don't tear it. This is an ideal tunnel formation. What is the next step after tunnel formation? The next step after tunnel formation, of course, is once you have made this tunnel, if this scleral tunnel is made, what is the next step is, I will do an anterior capsulotomy and ideally I would want to go for CCC. After doing the CCC, the rest of the step is same. I do a hydrodissection, Then I take out the nucleus. This time, how do you take out the nucleus? The section is not open. So, with a visco expression, okay, pressing on the posterior lip, pushing the vitreous and viscoelastic inside, and then trying to take out the nucleus outside. So, we generally take out the nucleus expression is by nucleus is taken out by visco expression, okay. And after doing this, what do you do? Clean the bag and put the intraocular lens. Rest is same, right? So, what is the benefit? Almost no post-op astigmatism. That is the main benefit. Okay. So, next we talk about is your phacoemulsification. What are the points you have to know for phaco? Again, you will draw together so that we have in mind what we are saying. On our copy, we should have the details. So, this is the 12 o'clock again and this is 6 o'clock. This time again, I am going to give the incision self-sealing only. Do you understand how the scleral tunnel worked? My external wound is here. Now I am traveling further. Then I am going to internal wound and I am puncturing. So, whenever pressure will rise like a flap, it will close because external is behind. Internal wound is here, but external is behind. That was triplanar. But when I am giving in the cornea, I start from the cornea, dissect further, then enter. This is called clear corneal incision. And in the clear corneal incision, I am entering here. Suppose this is mainly biplanar incision. So, clear corneal incisions are mainly preferred in phacoemulsification. Incision length has been asked as exam question. It is 2.75 millimeter to 3.25 millimeter. Now, this clear corneal incision, after giving this, my next step, of course, is CCC. Of course, first I start with the side port, which is an instrument which helps me to manipulate things. Okay. Then, once I have injected the viscoelastic, I have done the CCC. Now, what is the next step is hydrodissection, right? I am going to inject this water, separate the capsule from the lens totally. I should be very sure this has happened. So, my next step after hydrodissection, after doing a hydrodissection, I go for rotation of the lens. Okay, I rotate to ensure that my hydrodissection is complete. Once this is done, what next? Guess what next? Next is, after this, I am not taking out the nucleus as I have been doing in all the surgeries. Here, I will bring my phaco probe inside the capsular bag. What is phaco probe? It is giving ultrasonic energy to the nucleus, breaking the nucleus into bits and aspirating it. So, this phaco probe, the next question is, what is the frequency of phaco probe? We answer 40 kilohertz. Let's think together, all of you. We are saying we are doing the surgery in such a small incision of 2.75 to 3.2. Is it really possible? We have read, think with me, let's think loudly. We have read that the size of the lens is 9 to 10 millimeter diameter, equatorial diameter. So, think with me that any cataractous lens will have at least the nucleus size of 4 to 4.5. So, with such a nucleus size, how can you remove by 2.75 incision? The reason why I am able to manage, because I don't remove it at all. I am eating it up in the capsular bag, aspirating it there itself. I think you got it, right? And after this, of course, I cannot put the normal PMMA lens. The non-foldable lenses are made up of polymethyl methacrylate. This is again exam question, but we don't put a normal PMMA. What we will put? Foldable IOLs, which is the next question is foldable IOLs. Okay, so foldable IOLs are made up of, they ask you in the exam, we will learn foldable IOLs, they are made up of, we will answer acrylic and silicone. Most common कौन सा होता है? Most common होता है acrylic. Done? Okay, now let's have some idea about the surgery, that is phacoemulsification, and how it is done. We already have learned the steps, we'll just have a look at it. So, the first thing is to make a side port, right? On both sides, side port is made. This will help you to manipulation and doing the surgery nicely. Next is to inject the viscoelastic to form the anterior chamber, because once you have made a side port, what has happened? The aqueous has leaked out, and therefore to form the anterior chamber, we are injecting this viscoelastic. What would be the next step? We are going to create an incision, right? So, the make clear corneal. We have learned this, that what we make is a clear corneal incision with a keratome here. You can see the crescent shaped keratome. First, a partial thickness cut is given and then going through it. So, it's a biplanar incision. We'll remember it's a biplanar incision, right? So, this after making this clear corneal incision, what would be the next step? The next step is capsulorhexis. So first you are making as I have explained you, one straight, you give one cut here. And once you give a cut, you raise a flap of the capsule, isn't it? So see, this is what is happening. After giving the cut, the flap of the capsule is raised and then it is steered smoothly. See, this flapping is being raised. Can you see this? And then, so once this is done, it is slowly you tear it all around. Let's have a look. So here slowly we are just steering it round, all around to make a round smooth opening. Can you see the capsule? How we are doing this? See, that is continuous calvaria capsulorhexis. Okay? Is it clear? Okay. So this is one of the most challenging things and we really need a good training to learn how to do a capsulorhexis. So here you see that your capsulorhexis is almost complete and the capsule has been cut thoroughly. Completely, I mean to say. And a circular opening has been made. What would be your next step? The next step would be how the capsulorhexis is complete, as I said. The next step would be what? Injecting water under the capsule and separating the capsule from the whole lens. What do you call this? Hydrodissection. Okay. So this is what is hydrodissection. Right? Injecting water under the capsule. Right. So you have to see that your hydrodissection is complete and the water has reached all around under the capsule. Right? What is the next step is rotation. So why are you rotating? So that you ensure that your hydrodissection is complete. Have a look. So this is what is rotation. Next comes your phacoemulsification. We start with creating a very deep groove which we call as trenching, right? So we have taken a phaco machine and with ultrasonic energy we are creating, so we are trying to groove into the nuclear part of the lens, right? And what next we are going to do? We are going to break it into 4 quadrants and try to eat it up, break it into pieces and aspirate at the same time, okay? Here is the process of the phacoemulsification where we are breaking it into pieces and not only that, we will slowly eat it up and aspirate it from the capsular back through the phaco machine. Right? Can you see there's a silicone sleeve over the phaco machine, right? Yeah. Right. Because when you're using this machine, it will heat up and this is all to protect the intraocular structures. So here we are almost removing the last piece through the process of phacoemulsification. Right? And yes, this is look at the cannula. This is an IA cannula which we are using to clear the cortical matter. So what we are doing here, we are removing the cortical matter and cleaning the bag. Okay, now we try to expand this whole capsular bag with viscoelastic. Why? Because we have to put the intraocular lens into it. So here we are injecting the visco and this is your intraocular lens which we are implanting inside the capsular bag. It's a foldable lens which unfolds inside. Okay, lastly, you are closing all these openings with a partial hydration. Remember, you generally with partial hydration, that is partial thickness, we are able to close it. We don't need any sutures. It's a sutureless surgery, right? Hope the steps are very clear. So this is about phacoemulsification. Once we are clear about what is phacoemulsification and how we are doing and what are the questions asked. So next is what is MICS? If they ask you, you will say it is again phacoemulsification, but this time we are doing it in phaco which is done in 1.8 mm to 2.4 millimeter incision lens. So it's even smaller. This is called minimal incision cataract surgery. Okay, right. Another thing, what is phaco-knit? Now this one is even smaller. Phaco-knit, what we do, whatever the probe is there, we remove the silicone sleeve or covering of the probe. This is incision length of as less as 0.9 millimeter. After phaco-knit, just more of your factual knowledge that you should know, we put rollable IOLs. And what are rollable IOLs made up of? You will answer hydrogel. It is made up of hydrogel. Right? Good. So here you are looking at, this is phaco probe. This is how we are breaking the nucleus into bits, 4 quadrants, and then we are emulsifying and eating the nucleus in the capsular bag. This one is your side port, isn't it? This is the side port I'm talking about. And this is the phaco probe. Right. Again the same picture which is depicting the phacoemulsification. Look at this one. This is what is irrigation aspiration cannula looks like this. Okay, this is an IA cannula or irrigation aspiration cannula. So this is IA cannula, and this is the cortical matter which is being aspirated, and this is your side port, right? Okay. Now comes this very important question here. So if your patient has a mature cataract, you are not able to see the anterior capsule fully because of so much mature cataract, then what to do? Immature is easy. There's a background fundal glow. We can see things easily. Then you can stain the capsule. So this is your exam question. How do you stain it? Your answer is trypan blue. So first you put air inside so that this trypan blue is not directly touching your corneal endothelium or it will damage it. After that you put trypan blue. Then you wash it away and the capsule is now colored. You can do the surgery nicely. Okay? Is it okay? There's another question that which is the other dye I can use? No, this is not a question, I'm sorry. This is just extra information for you. The question is on trypan blue only, but we can also use ICG for staining the anterior capsule. What is ICG? We have learnt in your retina chapter, indocyanine green, right? So this can also be used as color for coloring the anterior capsule. But just an extra information, you just remember trypan blue. Okay. What is the next surgery which is the latest is femtolaser assisted cataract extraction. What are the steps we are doing with femtolaser? So first question is femtolaser, what is the pulse duration? It's already given, femto. So pulse duration, if they ask you, we will answer. It is 10 to the power of minus 15 seconds. Okay. Then second question is, what is the wavelength? You will answer 1054 nanometer is the wavelength. 5.3 somewhere it is written, somewhere 5.4. Right? So that is the wavelength of femtolaser. What are the steps we do with femtolaser? So the steps that we are following, first is, as you can see here, capsulotomy, which is so accurate and right? So and very predictable. So one is, of course, first is your incision. We can make the incision with laser. Second is we can go for CCC with laser. And third, we can break the nucleus into bits, which is called lens fragmentation. This is what is lens fragmentation. This is the third thing that you can do with the femto laser, right? And as we can see here, that the shape may be unpredictable when you're doing it manually. We are talking about this continuous curvilinear capsular axis. But when you're doing it with a laser, it's almost a perfect round cut. So, if suppose the patient comes to me for femto laser cataract extraction, I first take him to the laser room, get these steps done by the laser, then take him to the OT, and just the incision is made. I go inside, the capsule is already cut. I have to just remove it, remove the lens as emulsify it, it's already done. After removing that, clean the bag and put the intraocular lens, right? So this is what is femto laser assisted cataract extraction. So what we are saying is, the next thing that they can ask you, that what is the composition of the viscoelastics that you are using for the cataract surgery or any intraocular surgery. So you should know mainly these are methyl cellulose derivatives. Okay, HPMC, this is hydroxypropyl methyl cellulose. Another more viscous one which can give even more protection and cushioning protection to what? Corneal endothelium and other intraocular structures. Mainly we are trying to save the corneal endothelium. So that is your hyaluronate, sodium hyaluronate. Just we will remember these two constituents of the viscoelastic. Similarly, when you talk about irrigating fluids, so what are the different irrigating fluids I can use? I can use a ringer lactate, right? So when you say ringer lactate can be with or without adrenaline. Okay, I can use adrenaline, or this will help to keep the pupils dilated. What is the second one? Second one that I will use, can use it, basil salt solution, right? So basil salt solution, it's almost near to the composition of the aqueous. It's mainly isotonic and consists of chlorides of, easy to remember, sodium, potassium, magnesium and calcium. So these are isotonic chlorides, right? But then we come to which is the ideal, the exam question, which is the ideal solution, you will answer BSS plus. So BSS plus ho gaya aapka. What is BSS plus? Along with all this BSS composition, we have glutathione, and this is considered the ideal irrigating solution for intraocular surgeries or cataract surgery, right? So we'll keep this in mind. So when we talk about the different types of IOLs, of course, my ideal site of IOL implantation is in the bag, because this is the original place where the lens was. So ideal site should be where the lens was already there. So it is capsular bag, posterior chamber IOL. If the bag is not there, if there is any posterior capsule tear, I don't have the support of the capsule, I can still put the lens in the posterior chamber and you can tie it or you can stitch it with the sclera, which are called scleral fixated lenses, right? But ideal is always, please remember, the choice of site of IOL implantation is capsular bag, right? Let's not confuse with best option written here. I'll explain you what best option here means. So, this is one. We are saying, and of course, ciliary sulcus is nothing but a narrow space between the iris and the lens, right? Sometimes it is not in the bag, it is in that space, that is called ciliary sulcus. If there is a posterior capsule tear and now you have to put the lens, what are the options? One option is in a PC tear situation, when there is no posterior capsule, no capsular support, then we have one option is ACIOL, one option is iris claw and one option is scleral fixated. So, in these three options, scleral fixated is considered the best option. This is what we mean here. Okay. So, what are ACIOLs and iris claw? Let's have a look. Okay. First, what we are seeing here is this is how the lens can be injected. Foldable IOLs are injected inside the capsular bag. So, we will see it in the videos also. You will appreciate better. Okay, next, this is what? This is the ACIOL we are talking about. How do I recognize? Is the haptic. This is the Z-shaped haptic of ACIOL. And you can see it is all implanted inside the anterior chamber. Can you see this opening out here? What is this exactly? This iridectomy. Why do I do an iridectomy? Wherever I am putting an ACIOL or I am putting an iris claw, I should do an iridectomy because if there is any pupil block, it shouldn't lead to pupillary block glaucoma or other complications. It should not close the angle. And it will only be possible if I have another opening, and so this peripheral iridectomy is made. Okay. So, keep this in mind. PI. Yeah. So, am I happy with the anterior chamber intraocular lens? No. So, if I talk about the ACIOLs, what are the difficulties or problems why I don't want to use it? So, what are the side effects of an ACIOL? If we have to think this way. Just make a diagram and you will understand. See, we can think it together. If this is suppose we are saying that the IOL is inside the capsular bag. Inside the anterior chamber. Do you realize what? It will damage, it can cause corneal damage. Number one, I can see it can lead to corneal decomposition or damage the corneal endothelium. So, cornea ko damage kar. What else I see? It can also cause inflammation in the iris uveal tissue, so it can lead to uveitis, right? What else? It can even cause, if I have not done an iridectomy, it can lead to your pupillary block glaucoma also, but otherwise it is, of course, can cause problem here in leading to glaucoma if there is any problem in the drainage. And it can cause bleeding leading to hyphema, right? So, this is what is UGH syndrome, is uveitis, glaucoma and hyphema. Hyphema is nothing but blood in the anterior chamber. Can just damage the tissues and lead to bleeding in the anterior chamber. That is causing hyphema. So, let's keep in mind these are some disadvantages and therefore, it is now no more or not a very good option to use. Iris claw lenses. Okay, iris claw once you have done, even we are using and doing this iris claw lenses for refractive correction. Where, see, this is the place where you claw the iris, right? And it is, if this type of haptic is called plate haptic. It is joined with the optic, this is called plate haptic lenses. So, this is an iris claw lens which is implanted here, and again I would like to do a peripheral iridectomy, right? Then we are talking about the PC IOLs as I just discussed. So, this is the typical PC IOL. Now, normally what is the length? Generally, we say it is around, the whole length would be around commonly 13 millimeters. Whereas, if you talk about the optics, it is around anything 5 millimeters. Okay. And in children, of course, it has to be smaller, right? Anything around 12 or so. So, keep this in mind. Now, what are dialing holes? So, these holes that you see in the lens, the dialer is an instrument. You just hook it into the lens, into this hole. And you can adjust the intraocular lens in the bag. If you want to rotate it, you have to set it. We do it with these dialing holes. And of course, you always move in a clockwise. Can you see? Appreciate this. Look at the shape of the haptic. If I go opposite, I will tear the capsule. So it is always clockwise. Okay. What are scleral fixated? Why I am saying so? Because it also has a loop here at the haptics. This is the place where the suturing is done with the sclera. So from here it will be sutured with the sclera. That is why this is scleral fixated lenses. Right? Then of course, what are the other types of lenses? Even PCIOL. Suppose normally when you are putting a PCIOL, you are just taking care of the far vision. For the near, again, there is no accommodation. So patient has to use near glasses because you have already removed the lens. If there is no lens, there will be no change of shape of the natural lens can only change the shape. So there is no accommodation. But we have a solution for this. We can use multifocal IOLs. It has a different zones and for different distances at which we can see. Okay, so we will remember option is multifocal IOLs if you don't want to use the near glasses. Another type of IOL, if you have a cylindrical power, too much of cylindrical power or astigmatism, we can go for toric intraocular lenses. So toric, can you see these 3 dots? It helps us to fix the lens into that particular axis. So it's an indicator here. Okay. So these are toric lenses. Okay. Then next, what can be some other lenses that you should know? One is heparin coated. Heparin coated mainly in places of where there is severe inflammation. So when you use this lens, this will be less inflammation. For eyes which are prone for severe inflammation, we should choose heparin coated lenses as it causes less of inflammation. What is the next? Blue light blocking IOLs. So when your lens becomes cataractous, it starts absorbing blue light. And you start getting not used to this blue light anymore. So once you are operated, this blue light may really trouble you a lot. And it's anyway not very good for the retina. So there are IOLs which can block this blue light. Okay, these are called blue light blocking IOLs. Then aspheric. What are aspheric? Very important. Where there is no spherical aberration. Do you remember spherical aberration? We'll talk in optics also that the periphery of the lens. So what we are saying, if this is the lens, right? Any refraction or bending is more from the periphery than it is from the center. More from the periphery. Okay? So that is called spherical aberration. So when you use aspheric lenses, there is no spherical aberration. So this is negated. That is why we should always opt for aspheric lenses. So now you know what are the different types of IOLs. Okay, so how do you actually decide what power you are going to put in the eye? So first question is, what is biometry? Method of calculating the power of intraocular. We have to calculate for each patient. So there was a time when there was none, it was not calculated, it was just put 20 diopters in every eye. But of course, we don't do it anymore. So calculating the IOL power is called biometry. Right? And how do you do it? So we take 2 readings. One is your keratometry reading and one is axial length reading. Right? Axial length, we have learnt in introduction. What is axial length? AP diameter, anterior posterior diameter. And how do you take it? We have learnt about A-scan, ultrasound, by which we can measure the axial length. And keratometry, of course, you should know, measures the corneal curvature. At the central optic zone, suppose this is the corneal area which is being measured, then we take 2 readings. One is K1, one is K2. The vertical is K1, horizontal is K2, and the average is taken as a K reading. Okay. So the normal that we use, what are the instruments? Let's understand here that A-scan, you have to touch the probe to the cornea. So it's a contact method, keep in mind. Do we have some other non-contact method? Yes. What is this? This is IOL master. So this is actually optical coherence biometry. Okay. So this is a non-contact method, and as you know, this instrument is called master. Why? Because it will measure the axial length. It measures the keratometry reading. It is going to measure your anterior chamber depth, and one more which has been missed here is white to white measurement. Anterior chamber depth and white to white measurement. Right? So white to white measurement, that is from one limbus to another limbus. So these are the some important measurements you can do with IOL master. And of course, keratometry, the usual keratometer, which is measuring the central optic zone of 4 mm. This is your called Jewell-Shiotz keratometer. Of course, the second you can do a corneal topography, and the third, of course, you are using the IOL master. So these are the 2-3 ways of doing the keratometry. Anyway, whatever it is, you have taken the axial length, you have taken the biometry. Now we have to put it into a formula, isn't it? What is that? Commonly used is your SRK formula. Now, SRK, of course, easy to learn if you learn it as Shah Rukh Khan. But what is the full form? Just know it. They may not ask you just for knowing. It is Sanders-Retzlaff-Krafft. Retzlaff-Krafft. Okay. So, these three sides. This is the formula which says, I have mentioned in the congenital cataract part as well, that any power that you calculate is A minus 2.5 L minus 0.9 K. L is the axial length. A is not the axial length. It is the L which is the axial length. K is the keratometry reading. What is A? We answer it is a constant. It depends upon the surgeon, the IOL and so on. Please remember that. Right? But this is most reliable, this SRK formula, when your axial length is anything from 22 millimeters to 24.5 millimeters. Longer and shorter, this we need some other options. Okay? So, we will just do a very quick look. A very quick look upon what are the different formulas, right? So, I don't want you to mug it up, but for information, you should know it at least. There are 4 generations. First generation is this SRK formula, which you have just learned with me, SRK1. Second generation becomes SRK2, okay? So, it will take a few more variations of the axial length and all. Just know what are the names of third generation. It is SRK by T, Hoffer's and Holiday 1. And fourth generation is Hoffer Q, Holiday 2, Haigis and Barrett. I know it's bad. I want you to learn also what I am teaching you also. I'll tell you what. We will learn what is asked. Once you know this, have a general idea. What will be asked? I told you the maximum, the SRK formula is very good for 22 to 24.5. Okay. If you have longer eye, what is the ideal formula? Shorter eye, what is the ideal formula? This is what they will ask. So, longer eye means you will answer the ideal formula is SRK by T. For shorter eye, again it is Hoffer's Q. Okay. And then they have asked you, this is your exam question. What about post-LASIK? So, post-LASIK, the corneal thickness is all altered, isn't it? You have already altered the, after doing LASIK, you know, no? We are ablating the cornea and altering the curvature of the cornea. We'll talk about it in detail in different chapter. So, but post-LASIK, if I ask you which formula? So, majority of the formula are based on keratometry reading, but not all. The fourth generation formula is mainly based on anterior chamber depth, white to white measurements. So, that is the reason, mainly anterior chamber depth. They are not dependent on this and not on the corneal parameter, not on the curvature and nothing to do with the thickness of cornea. Therefore, in post-LASIK, we will choose fourth generation. And the option in your exam was about Haigis. So, please, we will learn here. For post-LASIK, we will use Haigis formula. Okay, make a cue there, all of you. Right. So, once you know about how to calculate the intraocular lens power, what is biometry, now very important, and of course, I hope you remember in congenital cataract, I have just talked about how you will calculate the power, but you will undercorrect by 20% if the child is less than 2 years of age and by 10% if he is 2 to 8 years of age. Why? Because we want to take into account the increase of axial length that will happen when he grows. We are taking into account the myopic shift. Do you remember that? Okay, so we had left one part of the treatment of congenital cataract, and that was what is the ideal surgery. So, treatment of congenital cataract, we have already discussed what is the ideal time. What is the ideal surgery? What is the treatment of choice? So, now you know all the surgeries, easy to understand. We are going to remove the lens. Of course, that will be possible with anterior capsulotomy. We want to do phaco. But you know, in a small child, there is intense inflammation and very quickly there will be opacification of the posterior capsule. So, we are doing the phaco, but in the same sitting, I am cutting the posterior capsule centrally so that there is no problem. Otherwise, very quickly the child will be presenting with again difficulty. Maybe if he's a small child, he will not be able to tell also, no? So, what do? You will do lens aspiration. Why do you call it lens aspiration? Because the cataractous lens is very, very soft here. With primary means during the same sitting when I am doing the cataract surgery, apart from anterior, I go for posterior capsulotomy. And do you remember I taught you that in children there is a strong adhesion between posterior capsule and anterior hyaloid membrane. So, you have to cut that much part and a little bit of vitreous which is around to get rid of that area. So, we say anterior vitrectomy, right? So, what are we doing? Again, I am making the diagram. If you have forgotten, I talked about if this is the lens and this is the anterior hyaloid membrane and there is this adhesion here, right? So, what we are doing? We are removing the lens, aspirating. We are also cutting this capsule and little bit of vitreous. If this is the capsule, we are cutting the central part of the capsule and little bit of this adhesion and the vitreous, right? So, this is what is your, if this is the capsule, wait. We can show the capsule like this. If this was the capsule, right? So, you are cutting the central part of the capsule as central posterior capsule this much and also the vitreous part, right? Anterior. That's why you answer this way. I hope it's clear now.